Hello. A very good afternoon to one and all. I hope you are enjoying the conference so far. It is my pleasure to welcome you all for today's session. My name is Dr. Punita Vora from SJT University. Now, my colleague Dr. Komal Sharma is going to introduce our next speaker for today's session. So, let's start with the Congress.
Thank you, ma'am. Good afternoon, everyone. Without further ado, let me introduce our first speaker of the day, Dr. Cheena Singh. Dr. Cheena Singh is an associate professor in Department of Oral Medicine and Radiology at PGI Rohtak, Haryana, with 9 years of experience. She completed.
Ek second. Dr. Cheena, are you there?
She's there. She's there in the meeting.
Okay.
Yeah. She completed her UG at MDU Rohtak and her post-graduation in Oral Medicine and Radiology from Tirthankar Mahavir University, Moradabad. She is a certified tobacco cessation specialist from Gujarat University and holds fellowships in forensic odontology and orofacial pain, sleep medicine, and TMJ disorders. Dr. Singh is currently pursuing PhD at Desh Bhagat University, Punjab. With 7 years of experience in treating orofacial pain, she was awarded the Young Researcher Award in 2023. Ma'am, I'd like to give the dice to you. Please.
Over to you, ma'am.
Over to you, ma'am. Please have a good session.
Ma'am is there.
Amma, should I share the slides?
Yeah, Dr. Cheena. Good afternoon.
Good afternoon, ma'am. How are you?
Yeah, I'm good. Good to see you here and waiting for your lovely session.
Yes, ma'am.
Yeah, you can share your slides. We
Yes,
can't
ma'am.
see you. You can just try to use your this thing camera also.
Yes, ma'am.
Yeah. Now
I'm visible now.
Yeah.
I'm sharing is not turned on.
Tina, just wait. I'm just.
Yeah, just a second. So you'll be talking about your topic is?
Ma'am, e-cigarettes, action for the teenagers, ma'am. Call to action for teenagers, ma'am.
Then that is the hottest topic which should be addressed, I guess.
Thank you, ma'am.
You can see your screen.
Ma'am, slides are visible, ma'am?
Yes, absolutely.
Okay, ma'am. A very warm good afternoon to one and all. The topic of my talk will be electronic cigarettes, call to action for the teenagers. I am going to continue my talk under the contents introduction, what is vaping or e-cigarette. Both are the different things, but nowadays they are using as a synonym, so we should be able to differentiate between these two words or the things. Parts of e-cigarette, generation of e-cigarette, what are the e-liquids, why do teen vape? That is a very important topic nowadays socially. Is it safe to use e-cigarette? Side effects of vaping or e-cigarette, myths behind the vaping, punishments behind the vaping, punishments for the vaping, and the conclusion. We should think critically for regarding e-cigarette and the vaping. Starting with the introduction, with about 267 million tobacco smokers, India is the world's second largest consumer of tobacco products. The electronic cigarette or e-cigarette for many considered as a safe alternative to conventional cigarette has revolutionized the tobacco industry in last decades. Recent global trends have shown the emergence of electronic nicotine delivery system, which is also known as ANTS, also known as the e-cigarette or the electronic cigarette. 1 in 4 middle and high school students have used the tobacco products, with e-cigarette being the most popular. So what is an e-cigarette? So e-cigarette are electronic devices essentially consisting of a cartridge filled with the e-liquids. We have a cartridge in that in which the e-liquid is filled, then a heating element which heat the cartridge so that the aerosols are formed as in our conventional cigarette. So whenever we inhale that aerosol, the act of inhaling that aerosol is known as the vaping. So both are the different things. One is the e-cigarette, that is the instrument which we used, and the act of inhaling is known as the vaping. So what are the parts of e-cigarette? We have a rechargeable battery in that. We have a case. It can be of metal. It can be of glass, depending upon the its generation, which type of generation we are using. Then the heating element or atomizers, cartridge, and the mouthpiece. In few, according to the generation, we have a button to ignite that. So aerosol can be formed in that. So as in our conventional cigarette, we have various carcinogenic gases or the substances. Similarly, in this, we have few carcinogenic gases or the substances. This blue portion shows us before heating, and this pink shows after heating. So the e-liquid contain propylene glycol, which is known as the PG, then glycerol, nicotine flavoring agents that we adds into the e-cigarettes, that I will discuss later on. Others available are tetrahydrocannabinol or the cannabinoids. We mostly use the words cannabinoids or THC. You might have seen the words written THC. So that is the tetrahydrocannabinol. Then other devices, materials, wire, atomizer, fiberglass, wicks, poor shoulder joints, because whenever we will ignite through the battery by pressing the button on the e-cigarette, they will heat and they will release the aerosol, which is harmful for us. So these aerosol contains propylene glycol, PG, glycerol, nicotine flavoring agent, and others. They also contain acetaldehyde, formaldehyde, acetamide, diacetyl, which is very important and very harmful for our lungs. Although it is not important that it is only harmful for our lungs. It is harmful for our hair to till the toenail. So that I have also discussed later on. So the evolution of cigarette is very important. How do we progress from the conventional cigarette to this e-cigarette? Few think it is a status symbol, but no, I think it is not a status symbol. It will take you to your death. Okay, so the first generation is disposable e-cigarette, means it is not refillable. Okay, because as we move to the fourth generation or vaporizers, it is fillable. Okay, then second generation e-cigarette will pre-filled or refillable cartridge, so it is one time use, will tell you. Okay, then the third generation will have a tanks or modes. It is again refillable, but the amount of delivering the nicotine will be little bit high. As the name is telling, it has tanks, so it doesn't mean it has that water tank or no, it will have the quantity more than the first and the second generation. Then the fourth generation pod modes. Why they are pod modes, that I will also tell. Pre-filled or the refillable. From the second generation, we start with the refillable. Okay, the first generation is only one use. Once it is used, it is waste. Okay, then first generation, it is disposable e-cigarette. It's a type of e-cigarette designed to be used one time only. You cannot replace the cartridge or e-liquids in that. Okay, Then these devices are not rechargeable and refillable. As I have already discussed a little bit, it is not refillable. From the refillable, the generation will start from the second generation. Then they are discarded when it runs out of the charge or the e-liquids, as they are not chargeable. They are designed to mimic the look and the feel of combustible cigarette, that conventional cigarette which we are using, which we use. So it resembles that. You can see that resembles to the normal conventional cigarette. Okay, they are sometimes referred to as the cigar like. Cigar like means cigarette like. It looks like cigarette, but harmful, more harmful than that. Okay. Then the second generation e-cigarette. E-cigarette with pre-filled or refillable cartridge. As I have already told, from the second generation, we'll start with the refillable cartridge. It is a type of rechargeable e-cigarette or vaping product designed to use multiple times. So as it is not, you can charge it. Okay, it is rechargeable. So it can be used multiple times. It is not like the first generation, once it is used, so it is wasted. No, you can recharge it. You will have a connector with that. You can see in this box. It will come in this beautiful box to attract the people so that they can smoke more and more. Okay. E-liquid comes in a pre-filled or refillable cartridge. Substances may include nicotine, cannabinoids, same THC, CBD, tetrahydrocannabinol, and the cannabinoids, flavoring, solvent, or other substances. The cartridge is attached to the battery pan, which contains the battery, so as to charge it and to ignite your atomizer. So that's from this mouthpiece you will have the aerosols. So the act of inhaling that aerosol is known as vaping, because I have seen many people using the word e-cigarette and the vaping. See, they both are the different things. Okay. The cartridge and the battery pens are typically purchased separately, so they can be charged accordingly. Then is the third generation e-cigarette. So they are the tanks or modes. A type of rechargeable e-cigarette or the vaping product designed to be used multiple times. They are modifiable substances. That's why they are known as modes. Modes is modifiable devices, allowing users to customize the substances in the device. Then sub-home tank. Sub-home tank contains low resistant coils. It is designed basically to deliver a large amount of nicotine in a short kick. So to create a large cloud of nicotine with a stronger delivery or heat of nicotine or the other substances. Then comes to the fourth generation e-cigarettes. They are pod modes. Earlier was the only the mode. Now it comes the pod also. So pod mode is an cigarette or vaping products with the pre-filled or the refillable pods or pod cartridge with the modifiable system. Again, the pre-filled is pod. So, and modifiable system is mode. These are other examples of fourth generation devices. Pod modes come in many shapes, sizes, and the color. See, nowadays, as I'm more pressurizing on the teenagers, we here covered many schools to conduct the lectures on the e-cigarette, but few agree, few no, don't agree. But how much I think why few don't agree? So कहीं ना कहीं उनके मन में एक they have a fear in their brain. The student will be exposed to this habit. But I think the student should know this. Their parents should know. Their teachers should know they can indulge this much of the harmful habit, because students can carry even in the form of the mobile, in the form of the charger, even on the watches. You will see on the Google what type of pod modes are present or the deliverable to the different places. Even these are the rules that in the circumferences of 100 meter of your school it is not deliverable, but although the students are getting the services of these pod modes, god knows from where they are getting these services. So these are other examples of fourth generation. Okay, pod modes come in many shapes, sizes, and colors to attract the students, teenagers, so that they can use in more and more frequency. So common pod mode brands include the Zul and the Surin. So some in few articles you will see it is also known as Zuling. So they are compatible pre-filled pod cartridge that contains nicotine, THC, CBD with or without flavoring. So pod modes in our conventional cigarettes we have pre-base nicotine, okay? But in case of our this e-cigarette, we have less pH nicotine salts. They inhaled more easily and with less irritation to the throat than the free-base nicotine. Then comes to the vaporizer. You might have seen in the casinos or in pubs, they are the flavored hookah. Nowadays they are providing the flavored hookahs. So what that flavored hookahs basically have, they have the marijuana in the husk form, or and it is basically an inhalation device used to release the active substance of organic or inorganic materials in the form of an aerosol through the application of non-combustible heat. Vaporizer can be used to create the aerosols by the dry herbs, that can be a wax and oil, that can be the marijuana, जिसको हम we call in Hindi bhang. So this bhang is basically to create the flavored hookah vaporizers. Please make sure or your mic should be muted, please. Dr. Anuradha, please.
Dr. Anuradha, can you switch off your mic?
कहाँ पे पैर में कैसे
Then the e-liquids.
Sorry.
In all the cartridge, we have the e-liquids. E-liquid is a liquid that is converted into an aerosol by an e-cigarette or the vaping products. It is typically a mixture of water, food grade flavoring, a choice of nicotine level, cannabis, PG, that is propylene glycol, and the vegetable glycerin. PG and VG are the humectants. They are the basically to dry that area. Humectant is used basically to drying the substance. Used in e-liquid to produce aerosols that simulate combustible tobacco cigarette smoke. The role of propylene glycol and the vegetable glycerin in the e-liquid can change based on whether flavor or the plume. So these are the various taste or the flavors which are available in the market, which attracts the teenagers very much. Strawberry, pear shape, pear flavor, apple, mint, banana, honey, coffee, watermelon, cherry. So they choose according to their taste. See, it contains nicotine. So what we have in our brain, we have few receptors in our brain. So why once you smoke, then again you smoke, again you smoke, again you smoke, and in that one puff of your this aerosol is equal to the 20 cigarette you inhale daily. So in our brain, we have certain receptors at which when you smoke, the nicotine binds to that and you stimulates brain chemicals release will there. That chemicals will stimulate to you have a next puff. So smoke, 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 that creates your chain smoker. So that is harmful. Who are the people who vape? 33% adults vape to stop smoking, which is a myth. I have already discussed one, you are indulged in the habit of smoking, you again smoke. You cannot stop yourself to don't smoke until unless your counseling is not done, because it is a natural. When you smoke, the brain will release certain chemicals by binding to the receptors, and that will start a kick of your next smoking. Then 11.5% of ex-smokers who now vape. So they will be land into a more habit of smoking. 10% 11 to 18 years old who have tried vaping at least once. 41 million vapors are globally present. 7 countries where vaping is banned. So my main motto behind placing this slide is we all have seen this famous movies. Kabir Singh, can you see he is holding 2 cigarettes in his hands and this tere naam? So the cigarette, what is the reason behind the vaping? Why the students or teenagers are indulging in this habit? That may be the stress, pressure from friends, and the main is the cigarette you like one after another won't help to forget her. So in both the pictures, the stress is there, something the stress is there, and the lack of the awareness, I would like to say, that is more important. So why do teen vape? Either they might have seen some advertisements in which they show a beautiful pen to attract them, the flavors they like, then the peer pressure, social influences, and the nicotine. Most important is the nicotine. E-cigarette, this is the myth behind that the e-cigarette don't have the nicotine. No, they have nicotine in that. Okay. So one more thing I would like to add in this, as I'm working in a government institute, a tertiary center here. So when I talk to the patients for the cessation of the habit, what they mostly they complain, mm, whenever we go to the morning, we're not able to poo properly. So what is the reason behind that? Yes, they are right at their place, because as we have a receptor in our brain, similarly we have in our intestine also. When they smoke, nicotine bind to those receptors and will start the motility. As the motility will start, they will able to pass their stool. So the nicotine makes you dependent, totally dependent. Okay, you can't think, you can't breathe, you can't pass the stool, so it is harmful. From where the teenagers got all this information that you should indulge in this habit? Some social media, from the tobacco shops and their friends, so they can indulge into these habits. Are e-cigarettes and flavor hookahs safe for youth? Is only no, it is not safe. However, the World Health Organization suggests that e-cigarette cannot be considered as a viable method to quit the smoking due to the lack of evidence. But moreover, both FDA and CDC are actively investigating the incidence of severe respiratory symptoms associated with the use of the vaping products. Vapes can be a helpful tool for smokers that want to quit the smoking, and vapes are not safe even if they are less harmful than the cigarette. Both are true. This blue one is only true when this e-cigarette doesn't have nicotine in that. Okay, but the very less chances the company supplier don't put the nicotine. If they will not put the nicotine, how will their selling frequency will increase? Nicotine is basically one kick, two kick, three kick, and the kick. The patient will become a chain smoker. So that is the main reason behind the nicotine smoking. Why do we become the chain smokers? A white paper released by the Indian Council of Medical Research in May 2019 says that a cartridge in an e-cigarette contains as much as nicotine as a pack of 20 cigarettes. So now got the point why nowadays e-cigarette is buying so much of the trend. The liquid vaporizing solution also contains toxic chemicals, which is very much similar to the pesticides and the metals that have been demonstrated to be responsible for several adverse health effects, including oral cancer, disease of your heart, lung, and brain. So what are the harmful effects of e-cigarette? It increases your respiratory complication by respiratory irritation, abnormalities in respiratory function, lung edema, airway epithelial injury, and e-cigarette or vaping products use associated lung injury, EVLE. It is known as EVLE. Okay. So others, systemic or the endothelial inflammations is cytotoxicity, oxidative stress. So wherever you feel the oxidative stress, less oxygen, more predisposed to your multiply of your cancer cells. Okay. So very important feature that it has been observed into the ends. Okay. Electronic nicotine delivery system, or you can say the e-cigarette or the vaping, is the popcorn lung. So this is our normal lung. Can you see this area? It has been fibrosed. Okay. So why it is known as the popcorn lung? Because it was first observed into the workers who were working into the popcorn factory, and they were adding some flavoring agents to this popcorn preparation. So that flavoring agent was basically the nicotine and leads to the popcorn lungs in those patients. So all this will decrease your capacity to breathe, everything. They destroy your lung. Okay. Nicotine is very addictive. I have already discussed why it is addictive. Children are more likely to become addicted to nicotine at lower level than the adults. More than half of the current users want to quit, but because of they are too much indulged into the habit, so it is very difficult for them to come back to their normal life. E-cigarette release nicotine, carbon monoxide, and other pollutants into the air and onto the surface. See, there are three smokers: active, passive, and the third hand. So in this case, we are becoming the passive smokers, and when they these uh, aerosols will lie onto the your surfaces like floor and your clothes and where you sit on your sofas and other places, so that becomes your third hand smoker. So it is very harmful if you breathe from someone is aerosol. It is also harmful. Okay, kids who are exposed to have detectable nicotine in their blood and the urine, mainly in case of your third hand smoking. This is a bar diagram from the American Association of Poison Control Center. You have seen the bar diagram in the 2022 is the highest most. So this bar diagram basically to show the how the electronic cigarette and the liquid nicotine cases have increased from year to year. So what is the reason behind that? That we will also discuss in a little bit of our time. So they are the myths. Are they myths or the reality or the fact? So the first myth is nicotine is just like a caffeine. No, nicotine is highly addictive. Okay? It can harm the parts of the brain that controls mood and the learning. Okay? Then the second myth is vaping is healthier than the smoking cigarette. No. The chemicals in the vape juice are linked to the cancer, asthma, wheezing, and the shortness of the breath. Then the third myth is if I vape, I won't smoke. No, you are indulging more into the habit of the smoking. Fourth one is vaping does not hurt the people around me. That I have already discussed. We become passive, become third hand smoker. So how it can be the harmless for us? It is very harmful for us. Okay, because passive and the third hand smoking is very harmful. Then the last myth is e-cigarette just produce a harmless water vapor. No, it's just the tricks to attract the people to smoke. They see the companies have to sell their stock. They have to sell their e-cigarette. Somehow they have to sell the e-cigarettes and all that. But it is very less chances that they will not put any nicotine into the e-liquid. Okay, you will once smoke, then you will smoke second time. It means their selling is very good. So the e-cigarette, it is a myth. Okay, but the fact is vaping exposes you to the diacetyl, which is the main reason behind your lung disease, that popcorn lung. Okay, so they are the punishments acts for the vaping in India. Type of offense and the number of times the offense has been committed. First time offense, up to 1 year of jail, up to 1 lakh rupees in the fine, or it can both be possible. Repeated offense, up to 3 years in jail, up to 5 lakh rupees in fine, or both can be possible. Storing the e-cigarette, up to 6 months in jail, up to 50,000 rupees in the fine, and both jail time and the fine. The Prohibition of Electronic Cigarette Act in 2019 prohibits the production, sale, distribution, and advertisement of the e-cigarette. The act also prohibits the import, export, and transport of e-cigarettes. But still in India, e-cigarette is nowadays on the peak. Even in my area, I will not expose the name of that institute, but I daily used to listen this much of the e-cigarettes quantity has been found. This much of the your that cannabinoids, marijuana has been found, because my husband is in a bureaucrat. So many time he used to tell me this much of quantity, this much of the weight of the marijuana we got from this area, from this institute, from this institute. So from then what about these all the prohibition of electronic cigarettes? This I think this is not all fake or something. It is not acting according to the government. So this all is due to the lacking of the awareness. We should aware the people. This thing is also that can harm their life. To address this gap in the adolescent e-cigarette education, the Teen E-Cigarette and the Vaping Educational Resource (T-EVER) was created to allow an avenue for the pharmacists to teach adolescents about the dangers of e-cigarette use. See, in India, many educational resources has been created, but I think very few is in action. So this is for the pharmacists who are selling these e-cigarettes or some medications, some marijuana in many forms, some tablets. So this is the chart for them only. You can see under this chart, first they are the dangerous ingredients of the e-cigarette, immediate consequence of the vaping, long-term consequence of the vaping, talking with a friend who vapes. So these, they have prepared a chart to educate the students, to educate the buyers, so that they should not buy these e-cigarettes, especially for the teens. So my take home message is awareness is very important. People are not aware of the things, what they are doing, what they are going to land up in the things. So the awareness is very, very important. Parent teacher or student discussion is very important. Proper audio visual aids are very important so that we can guide the students. So if you will smoke this much, what can be harm behind that? So there should be a proper guidelines for every school, for the every areas to sell these e-cigarettes. And main, students should be educated regarding the punishment acts. Does your school have a tobacco-free policy that does not allow any tobacco products, including e-cigarette, on school grounds? If not, engage friends and teachers in discussion. Until unless, being a parent, if I will not open with my kid, this is harmful for you, this is good for you, so he or she will not come to know. So a positive discussion is very important. To create a positive aura in the family is very important, so that your kid will be open for with you. Okay, similarly in the school, for free communication material, this is the a link which I got from an article. So we need to not write off vaping as a safe alternative to smoking. It is not safe. Empower vape free youth. Thank you. Last but not the least, I would like to say thanks to Nooral sir, जिन्होंने एक कॉल, by requesting on even on a single call, he accept my suggestion for the presentation. And thanks to Punita Vora ma'am also for organizing this so valuable conference. Thank you ma'am. Thank you sir.
Thank you so much, Dr. Cheena. That was a very, very informative, very insightful lecture, and it was very thought provoking. And also, I'm sure a lot of teenagers are there in this Congress who are listening to your lecture. I'm sure it was a big eye opener for them. So, thank you once again. If anybody in the audience has any questions, then we'll be happy to address that. Or you can also put it in the chat box. Okay, thank you, Dr. Cheena.
Thank you, ma'am. Nice to
and-
meet you.
Yeah, same here. Thank you. God bless you.
Thank you, ma'am.
So we have our next speaker of the session. That is Dr. VM. Okay, Dr. WM Tilak. Dr. Komal Sharma is going to introduce the next speaker for us. Dr. Komal, please introduce the speaker.
Good afternoon, everyone. It is my great honor to introduce our next speaker for the session, whose research and articles have been frequently referenced and cited by all of us. His work has significantly contributed in making complex disease processes more understandable. I am thrilled to present Dr. W.M. Tilakratna, a professor of oral pathology, senior consultant at the Department of Oral and Maxillofacial Clinical Sciences, and associate dean at Faculty of Dentistry, University of Malaya. Over 35 years of experience, Sir has held distinguished roles, including Professor of Oral Pathology at Queen Mary University of London and visiting professor at universities across the globe. Sir is a former Dean of Faculty of Dental Sciences, University of Peradeniya, Sri Lanka, and past President of International Association of Oral Pathologists. a renowned researcher. He is listed in Stanford University's top 2% of world scientists and is the first Sri Lankan dentist to achieve this recognition. His main research focuses on oral cancer and potentially malignant disorders. He has published over 168 papers, written 2 textbooks, contributed to 42 book chapters. Sir is an editor for latest WHO classification on head and neck tumors and the IARC handbook on oral cancer prevention. Sir, we welcome you. I hand over the session to you.
Thank you very much. Am I audible?
Yes, sir, you're audible.
Let me share my screen first. Can you see my screen?
Yes, sir, we can see your screen. Yes, sir. Now we can't.
Dr. Tilakratne, your screen comes and then it goes actually. So could you please sharing again?
Can you see it now?
No, sir.
Dr. Tilakratne, please try again. It happens actually. Some
I'm
technical
trying.
glitches are there. Not to worry, Just couple of seconds, we have seen your slide and then it disappears.
Sir, first you open your PPT on the desktop and then share it.
Yeah, that's what I did because
It's okay, sir.
last night I upgraded my browser. I never had any problem.
No problem, sir. Just try for a few more minutes. You will be.
I just did a lecture to Savita about 1 hour ago.
So it's okay, happens sometime. It's in virtual mode, so some glitches are always there. You can log out and log in if that helps. Dr. Nurul, how we can help him?
Let me check and update. Wait.
Yes.
Just wait.
Dr. Tilak Ratne, could you please share your presentation to my WhatsApp or email?
Yeah, I'll email it. Huh?
Yeah, please.
Give me a second, quickly.
Dr. Tilak Ratne, I have sent you an email on your WhatsApp. You just look at it. It is my backend team's email ID. If you send your email ID, it will be easily shared. You just guide him to change the slide, and he keep changing the slides, and it's easily presentable.
There is a problem in my computer, basically.
No, you are audible and visible. So the slide is a issue. You just you just attach the your PPT to this number. You can WhatsApp as well, whatever is the comfortable. Or Dr. Tilaknatne, can we take our next speaker and then you can join in half an hour? Would you find?
Yeah, it's okay. Yeah.
Let me check with my moderating team. Dr.
Yeah,
Punita.
yeah.
Dr. Punita, am I audible?
Yes, sir. Yes, sir. You
No,
are
audible,
audible.
Dr.
Dr. Gitanjali is in also meeting room. I think her talk is after that. So could
No
you?
problem, sir.
Yeah. Could you take her first, and then we'll join Dr. Tilak Ratne. I think Dr.
sir.
Gitanjali is there in the meeting room.
Okay, Dr. Gitanjali, are you there?
Hello.
Yeah, she's
Yeah,
there.
hi. You're able to hear me?
Yeah, you are audible. Yeah.
Right,
can-
right. Please allow me to share my screen, please.
Yeah, let me introduce you as a speaker and then you can share your screen, ma'am.
Sure.
Yeah. Yeah, please, Dr. Komal will introduce you to the
Good
gathering.
afternoon, ma'am. Dr. Gitanjali Ahuja Mangi is a clinical dietitian and nutritionist with over 20 years of experience in clinical nutrition. She holds a degree from SNDT University, Mumbai, and a postgraduate qualification in clinical dietetics and applied nutrition from IHMCTAN, Mumbai. She also earned a master's in dietetics and food service management from IGNOU, New Delhi, and is registered dietitian with IDA. In addition to clinical expertise, Dr. Gitanjali is a diabetes educator, academician, and active writer, and she has contributed articles on nutrition to print media. She has guided wellness programs involving general practitioners and wider community. Dr. Gitanjali is an active member of IDA and All India Association for Advancing Research in Obesity. We welcome you, ma'am. Over to you.
Ma'am, you can share your screen now.
Sure.
Yeah. Ma'am, also switch on your camera if it's possible. We can't see you actually.
Hi, are you able to see my screen?
Yes, ma'am, we can see your screen.
Kindly allow me 1 minute to share my presentation, please.
Ma'am, but we can't see you. Is it possible to, if you can switch on your camera? Yeah, yeah, absolutely. We can see you now.
Hi, are you able to see my screen?
Yes, yes.
Are you able to see the screen?
Yes, ma'am, we can see your screen.
Great. Good evening, one and all. Am I audible?
Yes, ma'am, you're audible.
It gives me immense pleasure to address a young group of budding dentists, my fellow mates, and other delegates. Oral cancer is the sixth most common malignant neoplasm world over. Let us all join hands and work towards it so that we have better outcome in our patients. Moving to medical nutrition therapy in malignant neoplasm. What is a neoplastic disease? It's an abnormal growth of cells, which is known as a tumor. This can be of two types. Either it can be benign or malignant. What is the nutritional etiology that is linked to this type of cancer? Thanks to the modernization that we are undergoing, all the chemicals and carcinogens that we are exposed to from the pollutants, the food containers that are used made of plastic are, are releasing BPA, NOCPAH kind of elements which are released into food, which are entering the food chain and human body. Besides this, we have alcohol, certain viruses, limited consumption of fruits and vegetables, radiation, and not to forget tobacco and smoking as the major contributors to oral cancer. All these put together are initiating and progressing this type of cancer. What is the nutritional goal that we are looking at in managing oral cancer? The first and foremost goal that we have is to prevent and correct the baseline nutritional deficiency. A lot of patients present deficiencies of B complex vitamins, and because of which we first need to correct these deficiencies so that they are able to absorb their food very well. Preventing and correcting nutritional deficiencies, minimizing weight loss. If a patient is at a higher level or advanced stage of cancer, then cachexia, which is loss of muscle mass, is very common. Our sole aim is to minimize and prevent weight loss. Gaining weight or anabolism is very, very difficult at advanced stages. However, our sole aim should be to maximize their oral intake so that we prevent weight loss. Feeding them through oral channel is one of the best medium as the absorption and assimilation of food is maximum. However, if we fail to do that, we will have to look into other modes of feeding like enteral and parenteral nutrition. Let's understand enteral and parenteral nutrition a little more in detail. These are the different mediums through which we can support a patient nutritionally. Oral medium is the best. However, if that fails, then we need to give enteral feeds, which is through the help of the nose and stomach. If we fail to do that, the third medium is parenteral nutrition, which is intravenous infusion of food. What is enteral nutrition? Enteral nutrition is basically inducing a tube into the nasogastric area, which is called as a Ryle's tube. This tube, if it's at the gastric level or at the stomach level, we would call it as a nasogastric feeding technique. If it's a little lower in terms of the small intestine, then it is nasojejunal or nasoduodenal feeds. This kind of feeding is the best possible nutritional method to feed patients if not orally. The best way to feed enterally is by two ways. One is continuous feeding technique where constant drips are given. However, the second means is the bolus feeding method where every 2 to 3 hourly about 250 to 300 ml of feed depending on the patient's requirement is planned. If not enteral nutrition, or if this fails, if the patient is not able to tolerate it, then we need to move towards parenteral nutrition. Parenteral nutrition means pre-digested meal which is given directly into the bloodstream. This is intravenously fed, where we are bypassing the entire digestive tract. So, pre digested molecular form of these feeds are fed where we need to feed the patient for a little longer duration, so be it 5 to 7 days. Then, this kind of a modality is looked into. The ideal requirement of a patient would decide their nutrition formulation. However, an energy intake of about 25 to 35 calories per kg body weight is designed in these feeds. Protein of about 1.2 to 2 grams per kg body weight is given. This is taking primarily into consideration the muscle losses that happen at advanced stages. Fat of about 20 to 25% per of the total calories that are given is planned in order to take care of the caloric requirement. Besides this, we have other modalities to take care of the patients. If we are able to manage their nutritional needs orally, which is the best channel, if we aren't able to, we need to have nutritional supplements placed in their feeds. These patients should be primarily looked into malnutrition. If their energy intake is restricted, cancer patients easily go into malnutrition. That is why, besides oral feeding, if there is a need of increased requirement, we also need to place in enteral nutrition. However, if a patient is highly malnourished or has been severely deficit in their intake for a prolonged time, then we need to increase their intake over a span of time. So we would take it in a gradual manner, and we would want to get them at an optimum level. This is to prevent refeeding syndrome, which is very commonly seen in malnourished patients. Besides this, we need to take care of their muscle mass, the primary site of immunity. Exercise is one of the best medium to take care of the muscle mass. Strength training, which is using therabands, which is resistant bands, or static contractions if the patient is absolutely malnourished, is not able to have any kind of external resistance, then doing static contractions of a particular muscle group will help retain muscle mass and will avoid further muscle losses. Let us understand how can nutrition help in decreasing the risk of cancer. Certain pro-inflammatory foods are the markers to increase cancer. These are refined carbohydrates like white flour, maida, or red meat, excess of sugar, salt, saturated and trans fat, processed meat, which is full of nitrates. These kind of foods increase the chances of neoplasm. Increase in body fat, a very sedentary lifestyle, excess of fat at the abdomen are certain other factors which predispose a person to these cancers. However, let's take a look at certain foods which would help prevent or decrease the risk of cancers. The number one food we are looking at is omega 3 fatty acid. Omega 3 fatty acids, primarily found in fish, are extremely effective as they are polyunsaturated fatty acid. Besides this, we have whole grains, fruits, and vegetables which help in improving a person's health, not only from overall health perspective but also drops the risk of cancer. Besides food, physical activity, maintaining healthy weight, nursing mothers definitely need to continue this practice for a long time, avoiding a lot of caloric restriction, avoiding absolute fat diets is something which helps go a long way in preventing these instances. Certain fruits and vegetables appear to have protective effect on these cancers. The fruits and vegetables that we are looking at that are listed here are, if you look at the color red, it is primarily found in tomatoes, grapefruit, watermelon. This has a phytochemical called lycopene. Lycopene is a very potent antioxidant. So, fruits and vegetables have certain phytoestrogens and phytochemicals which help prevent these cancers. Lycopene, the red color which is found in tomatoes, is the only exceptional phytochemical which is available more to the human body when it is cooked. The only fruit, tomato is a fruit. The only fruit which is, the more it is cooked, the more it is available. Besides this, we have certain berries, red grapes, plum, which have the red and purple color, contributing to anthocyanins and polyphenols, which are very effective. Carrots, mangoes, pumpkins have the color orange, which is carotene. Besides which, you have cryptoxanthin and flavonoids, which are found in papaya, peaches, which are helpful. Spinach, avocado, turnips, asparagus have the classic green and yellow color, contributing to lutein and zeaxanthin, which are the phytochemicals which help prevent cancer. Cruciferous variety of vegetables. We're looking at cabbage, cauliflower, Brussels sprouts. These are not really very commonly used in India though. However, broccoli is very commonly used these days in India. So using all these cruciferous variety contributes to phytochemicals obtained from sulforaphanes. These are extremely effective. Last but not the least, The onion family that we are looking at, leeks and chives in garlic, have allyl sulfides, which are the potent phytochemicals helping prevent this condition. American Institute of Cancer Research, the AICR, has recommended certain guidelines to help prevent cancer. Maintaining healthy weight, being physically active, eating a diet which is rich in whole grains, fruits, and vegetables. The rule of pick five variety of fruits and vegetables put together reduces the risk of this condition. Limiting the intake of processed food, red meat, sugary and aerated drinks, fast foods, alcohol goes a long way in preventing this condition. Mothers should lactate their babies for protecting them and the young one from this condition. Limiting the overall intake of salt and sugar in your diet goes a long way in preventing this condition. The role of nutraceuticals and superfoods for cancer. Well, nutraceutical has certain promises where it helps in promoting the chemo and radiotherapy, which is really sensitizing the tumor cells to be able to work well on patients. So these nutraceuticals sensitize tumor cells so that the patient is able to take these therapies and get maximum benefit. Also, the targeted pathways that are used to treat cancer, nutraceuticals would help in these kind of treatment modalities. However, there are certain challenges which are faced while using these nutraceuticals for its bioavailability. Also, there is insufficient data that we have, besides which most of these need to be patented. So there is a long way to go in this industry. So, the 10 most common superfoods that are helpful in preventing the growth of neoplasm are, I would put turmeric as number one, which is the most common ingredient used in our kitchen. Turmeric has curcumin, the golden yellow antioxidant, which causes apoptosis of the tumor cells of the head and neck. Besides this, it also reduces lesions in the colon. We also have broccoli, which has sulforaphane, which helps in causing tumor cell death. We also have dark chocolate. The cocoa found in it helps in reducing the progression of these cells. Dark chocolate, when we define it as dark, the chocolate cocoa has to be 70% plus for it to be effective. The higher the percentage of cocoa, the better is it and more helpful would it be. Red wine, the only alcohol which is allowed and exudes some benefit, is red wine, for it's got an extremely potent antioxidant called resveratrol, the antioxidant which is found in red grapes, and this stops the aggression of mutated proteins. Thus, taking into consideration all these superfoods in your diet, if you are able to manage a very active life, you're able to manage your weight well, and if you eat healthy and a well balanced diet, then we together can fight this disease for life. Thank you. The podium is open to any questions from the audience. Hello. Hello, am I audible? Hello.
Thanks, thanks, Dr. Gitanjali. Thanks for sharing your insightful presentation.
Thank you.
Yes. May I ask my audience to ask question? They can either ask the question on the chat box, or they can unmute and they can ask the question. Any question from audience? You can ask any question pertaining to diet, how to manage the diet of the patient suffering from any malignancy pertaining, and especially oral cancer patient and all.
Good evening, madam.
Good evening.
I am Dr. Sirisha, madam.
Right.
Yeah, can we have the protein diet for a longer period of time, madam?
We need to
Or,
have.
Yeah.
Kindly complete your question.
Yeah, ma'am. Can we have the complete lifetime usage of any protein products for the sake of the weight maintenance or weight loss or any other thing, madam?
Well, talking about long-term usage of any product, it's not recommended at all, because all these products come with their additional additives and preservatives in it. A well balanced diet is the only diet that we are looking at as a long term perspective to maintain weight and health. So, using any kind of product is not the whole idea. However, following a balanced diet where you're able to add protein sources through foods like plant protein based, you have sprouts, pulses, beans, you have soya products, but not in cancer patients. However, besides plant protein, we could also add animal protein, which is lean cuts of chicken or fish, and eggs. These kind of foods should make your protein, at its optimum. You'd be able to manage with these foods.
What if we are totally vegetarian, ma'am?
If you're totally vegetarian, then intake of sprouts and soybean should help in taking care of your protein. Instead of using a protein supplement, if you're using, there's something called as sattu, which is black chana flour. If you're using that as a protein powder, replacement to a protein product, it will be of great value.
Sattu. What is it, ma'am? Can please come again?
Sattu is black chana entirely, which
Black
is
chana.
grounded.
Okay.
Right.
Thank you, madam. Thank you.
Thank you.
Dr. Gitanjali, there is one question from Dr. Pooja Wadhwa in a chat box. She's asking that deficiency of which vitamin is cause of oral cancer in women?
Mostly it is B complex vitamins that is lacking in these patients.
Okay.
B complex vitamins are lacking because they are not able to absorb their food, because of which you typically see blisters on the tongue. And folic acid, thiamine, which is B1, B9, B6, these are typical ones which are, deficit.
Okay. Any further questions? There's one question. Any specific diagnostic test for vitamin deficiency, ma'am? B12 deficiency.
So we would first see for symptoms. If we see a lot of weakness of muscle in terms of calf muscle pain or thigh muscle, a lot of weakness in the legs typically, then also besides that you have chelosis and glossitis or angular stomatitis. So these are signs of B complex deficiency. But yes, we could also ask them to do a vitamin B complex array of tests through blood. That can be done.
Okay. Thanks, Dr. Gitanjali, for giving the the answering the queries of yeah. Dr. Shrisha is saying thank you to you.
Thank you.
Yeah,
Thank you
thanks,
very much.
Dr.
And I
Shrisha, for
wish each and every one immense success in their
uh,
practice and their
just just
endeavors.
just
Thank you.
uh,
Yeah.
just for a while. There is a further questions are coming, Dr. Gitanjali. There is a one
Sure, sure.
question. Blood cancer patient with kidney problem. What would be the best diet? She is asking. Dr. Halini is asking the question.
Right. In cancer patients, depending on their treatment modality, diet is given. If they are undergoing chemotherapy, then a neutropenic balanced diet where nothing goes raw in their body with enough proteins as the macronutrient, the only macronutrient lacking in our Indian diet, from the Indian perspective, if we are looking at, it is protein and taking care of their requirement. Besides protein, taking care of their baseline deficiencies. So, giving a balanced diet which is neutropenic, if it is chemo, treatment modality of chemo which is used to treat these patients.
Okay. Okay, thanks, Dr. Gitanjali. If there would be any question, if you have time, you can stay with us for a while because our next presenter, Dr.
Sure.
Tilak Rachne, is going to present his presentation because his, there was some technical glitch happened, so we gone out of the turn actually.
No problem.
There's one question. Just hold on. Just concluding this question, and we'll go with our next speaker, Dr. Tilak Ratne. He's waiting for that. Just hold on. There's a one question in the chat box. Just hold on. Is green tea interfere with the iron absorption? This is the question, general question actually.
Yes, yes. Tea definitely interferes with iron absorption. And that is why, whenever you have your meal, a very common practice that people have is they typically have their tea or green tea after meal. It's a very wrong practice. Do keep at least 1.5 to 2 hours of gap after you take a meal or before you take a meal, you have green tea. So 1.5 to 2 hours of gap should be kept between tea and your meal.
Okay, thanks, Dr.
Thank you.
Gitanjali, for
Thank you.
sorting out the queries of our all attendees.
Sure.
There are many questions are coming, but we are bound to go for the next presentation.
Sure.
If you stay with us, or you can answer the question on the chat box. That is there actually. You can easily answer on that.
Sure.
We are with your permission. Can we move on to the next
Sure,
speaker,
please.
Dr.
Please.
Gitanjali?
Thank you. Thank you.
Yeah. So nice of you, Dr. Gitanjali.
Thank you.
So we are going with the next speaker, Dr. Tilak Ratne. Actually, due to some technical glitch, he is not able to share his slide. My technical team is sharing on his behalf, and he would be directing my technical team to start the presentation. Dr. Gitanjali, could you please stop sharing your PPT so that my team will, yeah. Dr. Tilak Ratne, you are visible. Can I say hello so that we can check?
Hi.
Yeah, you are audible now. Ryan and Amar, could you please share the slide of Dr. Tilak Ratne? Yes. Yeah, slides visible.
Right. Okay.
So, Dr. Tilak Ratne, the people who join later on, could you please give your brief introduction before going ahead so that the people have an idea?
Okay, go ahead.
Yeah. No, Dr. Tilakne, I'm requesting you yourself give your brief introduction because yes.
I feel it is not necessary, but I'm W.M. Tilakaratna. I'm professor of oral pathology at Faculty of Dentistry, University of Malaya in Malaysia, and I'm the past president of International Association of Oral Pathologists, and also I have worked in the UK, Sri Lanka, and now I'm working in Malaysia. All right. Okay, this is a very important topic for all the clinicians, pathologists who are dealing with oral cancer, oral cancer and oral potentially malignant disorders. That is why I chose this topic why management decisions of epithelial dysplasia are complex. Next slide, please. Yeah, this, I think those who have not been to KL, that's the vibrant city of KL, and this is the faculty of dentistry and also faculty of medicine at University of Malaya, the #1 dental faculty, #1 university in Malaysia, and this 60th rank university in the world. Next, please. What is the meaning of dysplasia? Now, dysplasia, this is a Latin term, as you all know. Dys means abnormal, plasia is growth, and dysplasia, the word together is abnormal growth. However, although we call it abnormal growth, is it that simple? It is not. We know there are a lot of inherent problems associated with dysplasia, not only in the management, but also the diagnosis. Diagnosis and management both have enormous problems, although we are living in a very developed world in terms of molecular facilities, etc. Next, please. Now, the first description of epithelial dysplasia is very simple. It was introduced by a person called Reagan in 1958, using the exfoliated cells from the uterine cervix, not from the oral cavity. Next. There are a lot of definitions which came over the years for for dysplasia. Now, one of the first ones in terms of oral cavity came from the very famous oral pathologist, Professor Pimbog, who has done a lot of work in India, although he's from Denmark. He defined dysplasia as a lesion in which part of the thickness of the epithelium is replaced by the cells showing varying degrees of cellular atopia. He said basically the parts of the epithelium, the cells are not normal. And then the Burkhardt and Maker gave another definition in 1981, a measure of tissue and cellular deviation from normal. So that's again a very simple one. In 1992, the Kumar et al. Gave a little elaborated one saying disturbance in maturation sequencing of the stratified squamous epithelium, and also some disturbances in cell kinetics of the especially proliferative compartment with cytological atypia. Next. Now, what we use, the definition at the moment, what we use is definition of epithelial dysplasia by WHO. Now you can see the third edition in 2005, fourth in 2017, and the last one is in 2022, which we did. Now, this is our definition of oral epithelial dysplasia in the 2022 WHO classification. Oral epithelial dysplasia is a spectrum of architectural and cytological changes as a result of accumulation of genetic alterations. And usually the dysplasia is seen in the background of various OPMDs, and they all have they indicate a higher risk or increased risk of malignant transmission to SCC. Next. Now, first attempt of a grading system in relation to oral cavity came from, again, Professor Pimbog and Professor Smith from Sheffield. Again, two pioneers in our field of oral pathology. And this is not a method that you use formula or anything. It is just matching the photographs. They had 75 plus, if I remember correct, photographs. And it is slightly quantitative scoring, but it is not 100% quantitative. Next. Now you can see how complex the problem is. Now, different people have tried to come up with different grading systems starting from 1969 to 2022. Our latest WHO classification. In between, myself and Professor Eddie Odell from the London also tried to come up with a grading system. And none of these grading systems serve the purpose of grading 100%. Even the WHO classifications are not without problems. They have various problems. Next. Now, this is the 2005 classification, the third edition. Now, here you can see we have 5 categories: hyperplasia, mild, moderate, severe dysplasia, and carcinoma in situ. Now, this is not appropriate because there is hyperplasia. You can't have a grade of hyperplasia in dysplasia. So, this was abandoned. Next. And the dysplasia grading is very, very complicated in the case of oral cavity due to the very complicated histological architecture in different parts of the oral cavity. But if you take areas like cervical epithelium, now cervical epithelium is a very regular strip of mucosa, the epithelium. So we can very easily grade them into grade 1, grade 2, grade 3. This is called cervical intraepithelial neoplasia grade 1, 2, and 3. But we cannot do this correctly in the case of oral cavity. We tried to do whether we can do it, but we have shown that it is very difficult. Next. Now, this is a research that we did a long time back, Professor Odell from UK and myself. Now, we tried whether we can use the SIN criteria that we use in cervical epithelium to oral cavity. We call it OIN, or oral intraepithelial neoplasia, but it doesn't work well, because you can see if you look at moderate dysplasia, WHO grading, it has OIN in 3 different areas, right? So mild also same, moderate also the same. So therefore, it is not a very good system. So we dropped that from the oral cavity. Next. Now, these are the criteria we used to the practice. So considered up to 2022, the 2017 WHO classification, that is the 4th edition, and we had 8 architectural disturbances and 8 cytological atypia features. Next. Now, 2017, you can see we have a 3-tier system, the WHO grading, that's called mild, moderate, and severe. And in 2017, we introduced binary grading system. That is, the dysplasia is graded into low grade and high grade. Whenever we call low grade, clinicians can follow them up, and high grade should be excised. This is the system used in larynx, esophagus, cervical epithelium, etc. But still, in the field of oral pathology, this is not consistently used. But we expected people to use it after 2017 and to have more data on the reliability of this in 2022, but we did not have that kind of good studies. Next. Now, this is the systematic review that we did recently, just to see whether there is enough evidence in the literature to decide what grading system is better in this complex area of pathology, whether it is the WHO 3-tier criteria or the binary high grade and low grade. But we found that the binary system, according to the few studies that we had from 2017, the binary system looks slightly better than WHO 3-tier system. Next. Now, I don't think we have given people an easy task with 2022 classification. We have increased the number of epithelial dysplasia features from 16 to 28. That's not going to be helpful. So I feel that, but in the future, we hope in the 6th edition of WHO Blue Book, we should be able to reduce these features by recognizing most biologically significant features. That is another area where we need more research from the researchers who do research in OPMD and oral cancer. Next. Now, if it is a good grading system, it should have some attributes. Now, more importantly, it should be clinically relevant, and the clinician should be able to identify what are the cases that should be treated over cases that can be kept under wait and watch. And the grading system should be reproducible, minimizing both intra and inter-examiner variability. The present system is not, even the WHO system, is not 100% reproducible, both intra and inter-examiner agreement. And very importantly, the grading system should be biologically significant in order to identify the lesions that are likely to undergo malignant transformation. Next. Now you can see the reality. Now, how complicated, how complex the deciding a treatment modality for epithelial dysplasia. Now, this diagram I produced for the Oral Cancer Prevention Handbook, the first Oral Cancer Prevention Handbook by WHO, IOCCON. So this is the diagram that I produced for the handbook. And you can see, see how complicated it is. Now, this is normal mucosa, and you get leukoplakia without any dysplasia, and mild, moderate, severe dysplasia grades. Now, you can see the complexity, why people cannot identify what the treatment method that they should give for a given grade. Now, you can see mild epithelial dysplasia, some of them transform into moderate, some of them stay static. Right? Moderate, again, with some treatment, habit intervention, etc. Moderate can become mild, and even moderate, some of them, they do not progress. They can stay as it is. And same with severe dysplasia, only a minority though. So that is where the difficulty. Now, we cannot adopt a particular treatment guideline or protocol for these different grades of dysplasia. Different patients behave differently, right? So that is a big problem. And on the other hand, if you look at OPMDs, some of them are molecularly, biologically benign. So we do not see malignant attributes. Some of them are pre-malignant. They have the malignant attributes in terms of the mutation, gene rearrangements, etc. And only some of these OPMDs undergo the epithelial dysplasia, not all of them. But you see how complicated that is. Deciding the treatment option for epithelial dysplasia is difficult because some regress without any treatment, minority of them, some do not progress, some progress. So that tells us how difficult to adopt a uniform treatment guideline for the management of epithelial dysplasia. This is what clinicians should understand. So that is why most clinicians practice a combination method. Now they look at the degree of dysplasia, they look at the patient factors more importantly, they look at what habits the patient has, etc., and patient socioeconomic status, etc. Because if you send the patient off, now patient might not come back if they are from very low socioeconomic background, because unless pain comes, they will not come to follow up. So all those features and factors are there. So clinicians should take the decision by understanding the nature of epithelial dysplasia according to this diagram and considering patient factors, etc., in order to decide the treatment modality for a given case. Next, please. Now, having said that, there are various problems associated with grading as well. So again, because we cannot get the correct dysplasia grading for some patients, now the problem we face is some patients may have undertreatment and some patients may have overtreatment, because dysplasia grading has a lot of inter and intra-examiner variability, right? So, and also I showed you the features, the list of features. There is lack of reproducibility among the individual features. And sometimes we cannot grade the quality versus quantity in the epithelium. And to make it even worse, there are factors which exaggerate grading. The exaggerate grading in the sense, some of the factors can exaggerate the features. architectural as well as cytological. Then we are giving a higher grade of dysplasia and patient is going to have over-treatment. And the present grading systems, as I alluded to you earlier, the grading and clinical behavior sometimes does not match. And also in our part of the world, we have a lot of verrucopapular lesions in the background of submucous fibrosis. They are very difficult to grade. Next. So this is one example. Now, you all can see some funny structures on the surface of the epithelium. They are the fungal hyphae or the candidal hyphae. When a leukoplakia lesion is superinfected with candida, you get epithelial dysplasia-like features, or the present epithelial dysplasia features can get exaggerated. So then we give a higher grade of dysplasia. So my advice, if your patient's biopsy, when you do a biopsy from leukoplakia, if there is candida superinfection, I think pathologists should not give definite grading. So pathologists should ask the clinicians to give a course of antifungals and do a rebiopsy after 1 or 2 months, and then you can grade correctly. Otherwise, you are going to end up with the higher grade and leading to overtreatment. Next, please. Now, what are the reasons for lack of agreement in grading? Subjectivity in evaluation of established criteria and lack of calibration of used criteria. What does that mean? So ideally, those pathologists who practice in one pace, the inter-exam variability is much less. Now, therefore, I think I advise all the pathology societies, oral pathology societies in different countries to calibrate their pathologists in a nationwide calibration study, which we did in Malaysia recently. And also, we do not have enough research evidence to identify the features or criteria that are more important for predicting malignant transformation. Now, all these things attribute to difficulties in taking a proper treatment decision for epithelial dysplasia. Next, please. Now, this is what I was talking about, the impact of calibration. Now, if you calibrate, now you will see all the pathologies get better inter and intra-examiner variability, inter and intra-examiner agreement. So that we showed with the nationwide calibration study we did using all the practicing oral pathologists in most of the practicing oral pathologists in Malaysia. Next. Now you can see here the pre-calibration and the post-calibration, the kappa values, there is a significant improvement, right? If you look at the inter-observer, the variability, here it is 0.19 and it has improved to 0.4. So, and also the binary grading, again, you can see it has improved from 0.4 to 0.58. So that is significant improvement after calibration. So therefore, I advise all the oral pathology bodies, the societies in different countries, now get all your oral pathologists and do a calibration study, and you can get rid of these problems of grading epithelial dysplasia and lead into better treatment and appropriate treatment for your patients. Next, please. Next. Now, this is how the criteria put forward by Eddie Odell's group in application of dysplasia reports to clinical practice. So that's very important for the clinicians. We know that the distinguishing lichen planus from true dysplasia is problematic, so that we need to keep in mind. And a biopsy negative for dysplasia does not exclude an OPMD unless you can give an alternative histological diagnosis. That's very important. Then biopsy with an unexpected negative result should trigger further biopsy if abnormal mucosa is present. That's a clinical decision. Now, the clinician expects a positive dysplasia grading, but it's negative. and the clinically the lesion looks suspicious, and do a rebiopsy. The presence or absence of dysplasia is arguably more important than the grade, right? So that you have seen with the diagram, symmetric diagram, I showed you the complexities in dysplasia grading. Some mild transform into, moderate transform into, severe transform into. So therefore, what you need to identify is whether there is dysplasia or not. So that is more important than sometimes the grade, whether it is mild or moderate. Is less important than whether there is dysplasia present or not. Next. And if you have different pathologists in one department practicing, now get consensus reporting at least for some time, then you calibrate yourselves very well. As I showed you earlier, candidal infection is a confounding factor for dysplasia diagnosis, and first eliminate candida before giving correct grading. Now, if you see epithelial dysplasia in a child or very young adult, it is a very rare thing, but it warrants investigation for an underlying syndrome or any other disease like Fanconi anemia. Next. So whatever said done, how do clinicians treat epithelial dysplasia? Now, this is what majority of the treatment centers across the world do. Mild dysplasia, just wait and see. You do habit intervention and all other the treatment, but don't go for surgical treatment. Just observe. So some of these things will revert to normal, and some of them will stay as it is. So until such time it transforms, you can follow them up in regular intervals. Moderate epithelial dysplasia, majority, especially in our part of the world, will go for surgical excision, knowing the fact that a lot of patients are lost to follow-up. And in the developed world, in a lot of centers, still, even moderate epithelial dysplasia, they follow them up, wait and see method. Severe epithelial dysplasia, whatever said and done, I strongly recommend for surgical excision. Next. Now, the reality, by looking all these things, you would have realized the management of epithelial dysplasia is complex. It is not simple because of the problems associated with dysplasia grading. Dysplasia grading should be simplified. So that is what people are working on. So we are also working on, some of my PhD students working on to find out a simplified, more reliable grading system. A lot of people are working on that. Hopefully in the future, we will come some simplified grading system. We need to identify a grading system which has very less subjectivity with very little inter and intra-examiner variability. Significance of all features of this should be researched in order to identify their biological significance. It's very important. We can't be using 28 features, but identify the most significant features which are attributed to a transformation. With some of these features, we don't know whether they're just bystanders without contributing to oral carcinogenesis. We don't know that, so we need more research. And also, in the future, artificial intelligence may have a role to play in dysplasia grading as well. We are also working on that. But a lot of people working on AI. Now, every sector, now the hot topic is AI, but human knowledge and human brain cannot be replaced, at least for some cases, by AI. But we are hoping for the best, but we will have a better grading system in the future to make dysplasia management treatment less complex. Thank you very much. Next slide, please. Right. Thank you very much. If there are any questions, I am more than happy to answer.
Thanks, Dr. Tilak Ratne, for joining. Though we have some technical glitch, but it's a very diamond knowledge we are getting from you. And it's very in-depth about the all dysplasia, their grading and intervention. And we let them in future. We expect that we are getting a more simpler both treatment as well as grading. Any audience they can ask a question. They can unmute and ask question to Dr. Tilak Ratne. Those oral pathologists who are listening, who are with us in a meeting room, they can ask question. Yes, there is a one question from Dr. Himali. Is there any IHC biomarker particularly can be used?
So I hope you are expecting, you are asking whether there's any specific
Biomarker.
immunohistochemical marker to grade epithelial dysplasia. But we don't have a marker as such for dysplasia grading. But we know some people use things like P53. If there is definite P53 mutation, it is a more sinister sign to believe that it is on its way to become a cancer. But in routine diagnostic practice, there is no immunohistochemical marker to grade epithelial dysplasia. All what we do for epithelial dysplasia grading is the use of H&E sections, the hematoxylin and eosin. That is the accepted practice all over the world.
Yes, thanks, Dr. Tilak Ratne.
Can I ask a question?
Yes, yes.
Sure.
Yeah, Dr. Madhura here. Good evening, sir. That was a very insightful presentation. Yeah. Sir, one small thought process about when we actually look at the subjectivity in grading epithelial dysplasia to make it more objective. Can we think about the DNA ploidy analysis?
Yeah, good question. Actually, I didn't talk about the molecular side of epithelial dysplasia. Now, we have loads, hundreds, if not thousands of papers on molecular markers in oral epithelial dysplasia. If you have read one of our previous, many years ago, a review on molecular markers of epithelial dysplasia, there is a whole lot of things. Now I think we have more than 3-4 times than that article time. Well, the two things at the moment which we have recommended that in WHO Blue Book also. We believe that will have some role, if not now, in the near future, is the DNA ploidy and loss of heterozygosity. Now, those two things are associated with reliable malignant transformation. In some places, DNA ploidy is being used, especially I know the Eddie Odell's group, they are experts in DNA ploidy work. So they say you can predict the malignant transformation potential by doing DNA ploidy and loss of heterozygosity. More than loss of heterozygosity, in simpler methods, you can do DNA ploidy. So therefore, yeah, it is out of all the molecular jungle we have, DNA ploidy and loss of heterozygosity are the two molecular things that we can reliably do for prediction of malignant transformation, not to grade dysplasia, but to prediction of malignant transformation. Good question.
Anyone else who want to ask question? So there is no question as of now. Dr. Tilak Ratne, if you have time, you can stay with us. And maybe if some questions comes, we can ask after this presentation of Dr. Kulkarni. So with your permission, Dr. Tilak Ratne, should we move on to the next speaker?
Yeah, sure. Please go ahead.
Okay, thanks. Just let me check. Dr. Kulkarni, are you there? Can you unmute yourself and open your camera?
Sir, just 5 to 7 minutes I'll take. I got some issue here.
Okay.
I'm connecting my net and laptop. So 5 minutes I'll be taking.
Okay. Should we take...
If somebody is ready, next picture, you can proceed, sir.
Okay.
It's just 5 minutes.
Okay. Okay. Dr. Basavaraj Bhagwati, are you there in the meeting room? Let me check. We are waiting, Dr. Abhay Kulkarni. And if you have any issue, you can forward your presentation to us, and our team will share, and will save your time. You are audible and you might be visible. So if you have an issue in sharing your slides, you can forward it to, I'll send you my email ID. You can forward it. Just the way Dr. Tilak Ratne did in the last presentation. So by the time Dr. Kulkarni is about to share his
Yes,
presentation,
sir.
let me.
Yeah.
I'm just introducing you formally.
Sir, just a minute.
Our team can run your slide on your behalf, Dr. Kulkarni. You can just guide them for
Yeah. Just a minute, sir. It's the net is having some issues, so it's not
Okay.
getting connected. That's what.
Mhm.
Or otherwise, I'm in front of a laptop.
Okay. So let
It
me.
will just take within 2 minutes.
Yeah. So let
Yeah. You can
utilize this
introduce.
time. Let me introduce you, and then you can join. Yeah. So our next presenter is Dr. Abhay Kulkarni, and he's presently working as a reader of oral medicine and radiology, MIDS Dental College, Latur, and he's pursuing PhD at Singh Dad Dental College, Pune through MUHS Nasik. He finished his graduation at VP Sangli in 1995 and was in private practice, then finished his MDS in 2012 from PCDS Gopal MP and was working in PDU Dental College Solapur for last 12 years, from 12 to 24. He has got 42 publications on his name with 8 national and 4 international. He has published 5 books in his name. It's a great honor that he is author of a book, and he published 5 books in the name of the subject with 4 books on dental awareness. In the vernacular language, Marathi, Hindi, English, and Kannada. He has 10 copyrights for his name for original concepts in subject from Government of India. He has applied for 3 patents for new instruments. Recently, he has been awarded by Avishkar Award at university, inter-university level by MUHS and Charka National Award for Excellence in Clinical Dentistry. He has one spiritual book on his name in Marathi. So he is having his take on spirituality as well. And he is actively involved in tobacco control and cessation in Latur and surrounding region. This is from our side, Dr. Kulkarni. I have introduced
Just a
you, and
minute,
I
sir.
hope, yes, that
Yeah.
your internet is fine with you, and you would be sharing your slides.
Just a minute, sir. I'm not getting it still. No, sir. It will take little time. I don't know what has happened. I'm trying all the best from my this thing. It's taking time, sir. I'll
Okay.
take 5 minutes more.
No, no, no. You take time, Dr. Abhay. It happens sometimes in a technical world. It happens actually. Anybody from our learned or audience, all IOCCONians, those who are in the meeting room, anybody have any paper, any work, they can we can utilize the time, and by the time Dr. Abhay Kulkarni join, we can go through your work. Anybody have any prepared paper, etc., any presentation? So uh, we love to see their work actually. Otherwise, we'll wait for Dr. Abhay Kulkarni, because after that, Dr. Baswaraj T. Bhagwati, he's supposed to join, and he would be joining again in 10 minutes. So we have to wait for this 10 minutes, and it happens in a this, we are in a virtual world. When technical glitches, internet connectivity, many things is there. So just bear with us, and we definitely, when Dr. Abhay get his internet signal back, and his device is in order, we'll definitely connect. By the time, just wait, and we'll back soon when Dr. Abhay Kulkarni's presentation is slides is live and visible. Thank you.
Sir, there is one question on dysplasia. Can I ask right now?
Dr. Tilak Ratne, are you there? I think he left. Just hold on.
Okay, let it be then. I'll put it on the chat box afterwards.
No, he left.
Is the next speaker is not ready, sir? Because I don't know what
no,
has
he's also, he was there in the meeting room, but he thought that you are coming, no, so he is away actually.
I'm
He
so
would be
sorry,
joining.
sir. I just
He would be joining in another 10 minutes actually.
I don't know what has happened suddenly. It was working till this time, but laptop
By
is
the
not
by
picking
the
up, and
by
I
the
didn't.
by the time any subordinates are helping you to make your presentation visible, why not you just start giving the background of your work and all. It's your own work actually, which you have shared. So let's give them the
Yeah, yeah.
background, and now let's utilize that time. And by the time when you have the connectivity, your subordinate or anybody who help you to get your presentation, your slide
Okay.
visible.
Okay. I can give you verbal this thing.
Yes, yes, please.
Little. Yeah. I'm working on as such, I'm designing a biomarker for oral cancers and oral submucous fibrosis. And the data which I'm having, oral cancer data is not available with me right now. So my presentation doesn't include the oral cancer data. We are having a just oral potentially malignant, commonly occurring oral potentially malignant disorder, that is oral submucous fibrosis, and tobacco users and non-tobacco users. Like non-tobacco users are my control group, and tobacco users without oral lesions, any oral lesions I had taken into the consideration, and I am finding out salivary metabolites in that. So analysis has been done, and we are making this like a reliable tool for rural population, especially, which can be used easily, and that can be used for a mass screening in future. And there are 4 groups in which I have done my study, and out of that 4 groups, the oral cancer data, as I told you previously, it has been not available with me right now. But oral submucous fibrosis, tobacco users and non-tobacco users, all the data is available with me. And with the data which I am having right now, I can definitely say that there is a reliable biomarker that can be designed by the method which I am going to describe rather. So that is a brief idea of my work. This I had done my work in Sholapur and surrounding district. That time I was working in Sholapur Dental College. Recently, I have been shifted to Latur, and it was being done with gas chromatography, mass spectrometry. Saliva can be easily used for this thing as a diagnostic tool. And the salivary metabolite profile is very less studied. So I have designed this as taken this as my topic of research. And like if you try to collect serum blood from somewhere, it is quite difficult and the patient may not cooperate. For a mass screening, you need a very easy tool where the patient's cooperation is much more important. So, especially in the rural area where I am living, there is a smokeless tobacco habit is, I mean, widespread in the rural areas, and patients are having, I don't know what kind of a pleasure they do get, and they just so many patients we do get of this thing, smokeless tobacco, plus the lesions associated with, most commonly all of them are having the lesion associated with a them is oral submucous fibrosis. Invariably we do get, and so we decided to have something useful for them, and uh, with that I am working on tobacco control and cessation also. I'm giving them the idea of the tobacco control and cessation. As in the first lecture itself, after Garibasappa lecture, sir has taken a lecture, I had told ki tobacco cessation and this thing control should be made aware to the every person's family members, because that is a need. And if you make aware that such kind of a thing is available, uh, where their family members can just think of skipping the tobacco. I mean, they can leave the tobacco habit easily. Their family members will support uh, to adapt the tobacco this thing. So this is what is the my idea, and for that I am working very this thing. And to tell you, the tobacco control and cessation centers which are being started in the dental colleges, there I had taken initiative and I had given Dental Council of India the suggestion. And with that suggestion only, I had received a letter of appreciation from Dental Council of India also. And then this thing, it was been implemented in the dental colleges. I think I could be able to see the meeting launch right now, but I'm not able to join it. Yeah. Yeah. I think I could join. Just a minute.
Yes, Dr. Kulkarni, take time.
Yeah.
Recording in progress.
I think I'm there.
Your slides are not visible, Dr. Abhay. Yes. Your slides are visible, Dr. Kulkarni. Your slides are visible. You can unmute and you can start your presentation. Can you move to the next slide? Yes, it's working. Could you please unmute your microphone, Dr. Abhay Kulkarni? Dr. Kulkarni, you are not audible.
See now, am I
Yes.
audible?
Yeah, you are audible now.
Yeah. My apologies, first of all, for making the delay. Very sorry. I'm very happy that I am a part of this. I am thankful to all the organizers, those who have given me a chance to present this. The topic of my presentation is salivary metabolites as a diagnostic biomarker for oral submucous fibrosis. It's not moving now. Introduction. Metabolomics is a systemic study of metabolites, which are small molecules generated by the process of metabolism at cellular level, tissue level, or of a whole of organisms. It includes a wide range of metabolites like lipids, peptides, amino acids, nucleic acids, vitamins, organic acids, carbohydrates, and thiols. Nicholson defined metabolomics as the comparative quantitative analysis of all the metabolites of an organism or specified biological sample. The term metabolic profiling is also used as a general descriptor for the simultaneous measurement of multiple metabolites in a biological sample. Metabolomics is the systemic study of unique chemical fingerprints of low molecular weight endogenous metabolites or metabolic profiles in a biological sample. Metabolites that are important indicators of physiological or pathological states can provide information for the identification of early and differential markers for the disease and help to understand its occurrence and progression. Saliva contains a large array of metabolites, many of which can be informative for the detection of diseases. Salivary diagnostics offer an easy, inexpensive, safe, and non-invasive approach for the disease detection. Saliva contains a large repertoire of proteins and peptides, which are found abundantly in plasma too. This is a consequence of exchange of molecules with crevicular fluid at the periodontal pocket of the sulcus through passive diffusion, pinocytosis, and fusion pores of the acinar cells. This way, saliva can be very important biofluid regarding hormonal, immunological, nutritional, and physiological status of an individual. OSMF affects the submucosa and produces inflammation and increasing fibrosis, which results in a significant stiffness and inability to open the mouth. It affects people of Asian descent. The clinical manifestations of this chronic progressive disorder depends on the disease stage at the time of the discovery. The majority of the patients initially display a sensitivity to spicy foods as well as lip, tongue, and palate rigidity that to a varying degrees limits mouth opening and tongue mobility. The hallmark of illness is submucosal fibrosis, which mostly affects the pharynx, upper third of the esophagus, and the oral cavity. The countries with highest prevalence of are India, Bangladesh, Sri Lanka, Pakistan, Taiwan, Southern China, Polynesia, and Micronesia, these are the islands. Asian immigrants to the South and East Africa, UK, have also been subject to the several case report studies. According to the recent epidemiological data, OSMF cases have increased dramatically in India. The rapid spread of the disease is reportedly due to the increasing popularity of commercially available arecanut preparations, that is pan masala, in India, as well as in increase in the young people acquiring this habit as a result of easy availability and marketing initiatives. Prevalence of OSMF may vary depending on the definition used, the lifestyle of the population studied, and the clinical criteria used to detect OSMF. WHO reported more than 5 million OSMF patients worldwide in 2002, with the disease affecting a wide range of 11 to 60 years. This is the data which has been collected. The overall prevalence of OSMF is about 4.47% worldwide and 6.36% in India. Out of that, Uttar Pradesh having highest up to maximum highest up to 17.2%, then Madhya Pradesh and Maharashtra being 0.03 to 6.42%. Higher prevalence of OSMF was seen as the age group of 41 to 50 years of olds, and lower prevalence was seen at the age of 61 to 70 years of the olds. Based on gender distribution, the highest prevalence of OSMF patients were seen in males, while lower prevalence were seen in the females, but nowadays female prevalence is also increasing. Around 80% of the world's 1.3 billion tobacco users live in low and middle income countries. In 2020, 22.3% of the world's population used tobacco, 36.7% of men and 7.8% of the women. Nearly 267 million adults 15 years and above in India, that is 29% of all the adults, are the users of tobacco, according to the Global Adult Survey India done in 1617. Around 8 million people died from tobacco-related diseases in 2017. The most prevalent form of a tobacco use in India is a smokeless tobacco, and commonly used products are khaini, gutka, betel quid, tobacco, and jarda. Smoking forms of tobacco used are bidi, cigarette, and hookah. The total percentage of the deaths from the tobacco use was 10% in 1990, and this is increased 13% in 2019. The challenge arises with rising prevalence of a tobacco use in the younger population mainly. The National Non-Communicable Disease Monitoring Survey's findings released 2021 reported that 32.8% of the adults between 18 to 16 years used either smoked or smokeless forms of tobacco, and 28% used tobacco daily. 12.6% of the adults smoked, and twice of this proportion used smokeless tobacco. Tobacco use is recorded to be more than 40% in northeastern states of the India, a higher prevalence of smokeless tobacco use than smoking across most states and union territories. However, the prevalence of smoking than smokeless tobacco was highest in Meghalaya, Jammu and Kashmir, Himachal Pradesh, Uttarakhand, Haryana, and Andhra Pradesh. The predominant use of tobacco in the rural areas and dual use of tobacco, both smoked and smokeless forms, among men than women is notable. The average age of initiation of tobacco use is observed to be 21 years. Older adults aged 65 plus years were the highest proportion of current tobacco users in India. The prevalence use of tobacco among adolescents was 7%. Smokeless tobacco 5% was higher than the smoking. The prevalence of tobacco use escalated with every 10 years of increasing age, and notably more than twofold from 12% in 15 to 24 years of age group and 30% in 25 to 44 years of age group. The study is designed for unique chemical fingerprints of low molecular weight metabolite profiles. These are the indicators of physiological or pathological states and can provide information for the identification of early markers of the disease and help understand its occurrence and progression too. According to the most recent data reviewed by Milonsky et al., out of 1840, almost 500 metabolites have been identified in the oral cavity, and that too 359 found in the saliva. Need for the study. At present, biopsy is considered as a gold standard for diagnosing the oral cancer, but the invasive procedure is the major drawback of this method. To overcome these drawbacks, the traditional diagnostic methods, there is a need for an adjunct diagnostic tool for early and accurate diagnosis of oral submucous fibrosis and oral cancer in highly prone population. Molecular biomarkers are ideal for the objective screening and diagnosis, enabling the early detection of oral potentially malignant and oral cancer lesions, and therefore in current study, gas chromatography mass spectrometry is used for diagnosis of oral submucous fibrosis. Research graph. Compared with the analytical tools such as liquid chromatography mass spectrometry, that is LCMS, and capillary electrophoresis mass spectrometry, gas chromatography mass spectrometry, that is GCMS, is one of the most effective, sensitive, and reliable tools for metabolomic studies. GCMS produces reproducible molecular fragmentation patterns, making it an integral tool for metabolic identification. GCMS has shown high separation efficiency, which can resolve very complex biological mixtures. This technology identifies and quantifies a few hundred metabolites in a single sample. Research question: what is the difference in salivary metabolites between OSMF tobacco users without oral lesions and non-tobacco users? Picot formula, the oral submucous fibrosis, tobacco users without oral lesions and non-tobacco users. Exposure is gas chromatography, mass spectrometry. Comparator OSMF, tobacco users without lesions and non-tobacco users. Estimation is the presence of salivary metabolites, various salivary metabolites. The time duration was taken 36 to 38 months. This is the inclusive criteria which the patients with submucous fibrosis, age-matched controls, tobacco users, and the patients who had given the consent. In exclusion criteria, the patient who had taken SMF treatment, immunocompromised patients, systemic disease patients, salivary gland disease patients, and the patient showing clinical attachment more than 5 mm. The dependent variables are salivary metabolites, independent variables are OSMF, tobacco users, non-tobacco users. In short, the procedures, patients were seated in the dental chair, examination, case record was done. Saliva was collected early in the morning, preferably. Eating and drinking was not allowed for at least 2 hours of a sample collection. Each subject was asked thoroughly to rinse the mouth with water before it. This way, the group allocation was done in 3 groups, and then collection of a 5 ml saliva, and then it was storaged in minus 80 degrees centigrade, mostly using dry ice, and the samples were processed for the gas spectrometry. This way, the saliva was collected. This way, it was been stored. This is the gas chromatography mass spectrometry machine where it was been loaded for analysis, and the results which were obtained like this. It has got a library reading, and whichever the metabolites which we are finding, out of that 70% matching which are being shown to that, those were considered. Some were unknown metabolites and some were known metabolites. Out of this was our result. OSMF and 55 patients showed 259 metabolites. Tobacco users without oral lesion showed 217. Non-tobacco users showed 168. This was the percentage, the way it was been calculated. The OSMF showed highest percentage of the metabolites. The salivary metabolic profile is a mirror of the body, as it can provide a general outlook on significantly changed metabolites from aberrant enzymatic regulation, capture the oncometabolites originating from metabolic rewiring, and highlight altered pathways. All of these can become ideal metabolite markers indicating the ongoing oral pre-malignant lesions and diseases without obvious pathological symptoms. It can be considered as a risk indicator of oral potentially malignant disorder, that is OSMF, which is limited to our study findings. But it has to be taken consideration that it has got a limitation, that the concentration can be diluted due to some extent because of a continuous saliva secretion, mainly by the major salivary glands. Further research is needed with large sample size, and it can be used for mass screening, especially in the rural population with reliable results. We can collect the saliva easily and transport it and do the analysis and make the patient aware. These are my references. Thank you very much and warm regards. It's open for discussion if somebody has got some questions. Hello.
Thanks, Dr. Abhay, for giving your insight and presentation.
Yes.
Any from audience, anybody who want to ask question, they can ask question right now, or they can type it in the chat box, the question.
Good evening, sir.
Yeah, good evening.
May I know which metabolites were commonly associated with oral submucous fibrosis, sir?
Yes, madam. Right now those vary from study to study and from library to library, but thiols were found in most commonly associated with in our study itself. What happens, every gas chromatography or whatever investigation you are doing, they have got their different library. Okay. So whatever is been feed in that library, they will recognize that, and others will come as an unknown metabolite. So from only one study or two study, we cannot say ki this particular metabolite is more commonly associated, and this particular metabolite is can be a diagnostic marker for this particular disease. I hope your query is clear.
Yes, sir. Thank you.
Yeah, thank you.
Any more questions
Sir,
from anybody?
sir, may I know, like, from where did you get the salivary collection kits, sir? Are they available in India, sir? Like,
No,
good ones, reliable ones?
they are not available in the India. Right now, I have used just spitting method, but the salivary kits are available, and we can get it from the outside countries. I mean, right now, I cannot tell you the name of this thing source, but while finishing my dissertation, I got they had given me few samples of those things. Like, if you can take my number and you can contact me afterwards, I will give the details of those things, because they have kept somewhere in this thing which I need to search, and I'll give the information regarding this. Very nice, easily can be collected, because the patient is having problems sometimes in spitting and all those things, no, and the patient
Yes.
may not cooperate for a 5 ml also. I mean, the patient may not cooperate you. So they have got some pump that can be easily taken out, and the saliva can at least 2 ml, 3 ml saliva in one this thing spitting can be collected.
And was it an unstimulated saliva, sir?
It's
And
unstimulated saliva. It was not stimulated saliva. Again, the property changes with the stimulated and unstimulated. There is a separate study available on that.
Sir, may I have your number, sir? Myself, Dr. Ahalya, sir. I'm a reader in pedodontics from Vishnu Dental College.
Yeah.
Actually, we have planned few salivary studies, sir. I'm having this difficulty in getting the collection kits,
Yeah, sure,
actually.
sure. I'll be here. The thing is that I think you are available in that group, no? Or I'll
Yes, sir.
put my number here on the chat box itself. You can take this.
Yeah, yes, sir.
Yeah.
Dr. Abhay, could you,
94.
stop
Yeah.
sharing?
Yeah. 9422656860. Please put my hi on my district. 9422656860. Thank you, Anwar sir. Thank you very much for giving me the opportunity. And this is my honor that I could able to present it. And sorry for being late again. Should I stop it?
Yeah, you stop sharing your presentation, your slides. Yeah. Okay. So thanks, Dr. Abhay Kulkarni, for joining us as a speaker. And when you are not a speaker, when you are joining, again, you keep our program very interactive and, very live actually. You were in our IP, the Orofacial Pain Congress, and you made this very interactive and all. And we'd love to see you in our future programs. We would be doing one program in April, IOCCON. So maybe, you would be, be a speaker in that as well. Yeah. So with this note, can we, with your permission, Dr. Kulkarni, our next speaker, Dr. Baswa Rao is there.
Yes.
Should we move to the next presentation?
Yes.
Okay. Dr. Baswaraj, are you there? Can you unmute your?
Yes, sir. Yes, I'm there.
Great. Yeah, I'm not able to see you. Could you please open your camera and? Yes. Okay.
Am I audible, Dr. Anmo?
Yes, sir, you are audible.
Okay.
Visible.
This presentation comes from the Smith Institute of Research and Dental Science, Faridkot, Punjab. I'm thankful to MedSkill, who has given me this opportunity to put my study in this presentation scenario. My topic is role of viruses in oral cancer. You all know head and neck malignancy.
Let me formally introduce you.
Yeah, sure.
Okay. Dr. Baswaraj, yeah. Because you have to stay with us for another, say, 1.5 hours. You are judge of our paper presentation for speakers and all. So I'm just giving you the brief introduction. Dr. Baswaraj Bhagwati, he did his bachelor's in 1992 and then master's in dental surgery in 1996 from Karnataka University, Dharwad. And he is professor now. He is having 25 years of experience, and he served as a reader in a senior lecturer in other university. Then there are textbook authored by him. He co-authored the textbook called Positron Emission Tomography, is being published in Lambert Academic Publishing in 2020. There are many papers by his name, and he is. There are many papers which I am, seeing in his profile actually, and he attended many conferences and all. And over to you, Dr. Bhagwati. If I am missing anything, you can add on so that our audience have a better understanding about your Dr. Baswara. Just in a nutshell, that he is academician having say 2.5 decade of experience. So those young dentists who are who are in this program, IOCCON, they would listen him carefully, and he's talking on a role of viruses in oral cancer. And after that, he would be with us and he would be judging the paper presentation competition of the faculties. We have received 10 papers, and one by one we are calling them, and they would be presenting the papers. So over to you, Dr. Baswaraj T. Bhagwati.
Thank you,
I have
Dr.
missed
Anwar.
anything, you can add on.
Nothing. You have given an excellent introduction of mine. I'm very thankful for your introduction. Let's go through our presentation.
Yes. Okay.
Head and neck malignancy, you all know the most commonest cancer globally. Okay, and about 500,000 cases we are losing, presenting, and approximately 330,000 deaths are also happening because of this deadly malignant disorder. Head and neck squamous cell carcinomas are biologically heterogeneous group of cancers. They are the major cause of cancer.
Hello, it's not audible.
Yeah, I think his connectivity is gone actually, so he might be joining again. Just wait for a while.
There are some questions in chat box for me. Can I answer right now?
Yes, sir. You can utilize the time. Yeah.
I think Dr. Pooja has asked how the samples can be transported to the labs. So I just wanted to tell it has to be packed in a dry ice, and the dry ice is available. I have collected dry ice from Pune and Hyderabad. Even it is available in Mumbai also, and that gets evaporated within 2 days. That is 48 hours. I used to get 10 kg dry ice, and I used to put the samples in that, and then the transfer. This thing has to be transported to the center, and till the time we could get dry ice, it should be preserved in -80 degrees. And Dr. Madhura had asked what is the cost for it. So I had done 2-3 times inquiry, and the cost for this thing For me, it has cost nearly 1500 for each test. But I think in Pune and Mumbai, the cost is little higher. It goes up to 3000 rupees. So this is what two questions I could see for me.
I'm trying to connect Dr. Baswaraj on phone. So by the time, just be there, and we are coming back soon.
I think we are running from long time. That's why the problem is coming. Everybody is facing the problem.
Yeah, I'm joining. There's some network issues. I'm joining.
Yes. Yeah, please join.
Yeah.
Dr. Baswaraj, can you unmute yourself? Dr. Bhagwati, can you unmute yourself? We are not able to hear you.
Yes, now I think I'm audible.
Yeah, you are audible, sir. You are audible.
Yes. So tobacco and alcohol are well-known ecological factors. They are multiplicative rather than additive. So other than these two, we have studied microorganisms, especially and viruses.
Sir, your slides are not visible actually. Have you shared the slide?
Okay. Yeah, I've done that. Once again I'll do that.
Yeah, please.
Sir, now it is fine?
Yes, yeah, it's visible. Yeah.
Yeah.
Okay.
Okay.
You can carry on, Dr. Basura. It's visible.
Yeah. So diet's lacking of micronutrients is also one of the etiological factors. But slides are not moving, sir. Slides. Slides.
You can.
Yeah. So there have been studies on the microbiome of HPV positive tonsils on a head and neck squamous cell carcinoma and metastasis. And coming to today's discussion, it's mainly concentrated on HPV virus and head and neck cancers. We have very well noted literature on HPV viruses and role of HPV viruses in oral cancer. Coming to viruses are strongly associated with oral cancer. We divide the viruses into the viruses which are strongly associated with oral squamous cell carcinoma and less commonly associated with squamous cell carcinoma. Epstein-Barr virus, hepatitis virus, herpes virus. Then coming to today's discussion, that is human papilloma viruses. So let's see into the human papilloma viruses. So we have a vast variety of viruses in HPV viruses, group 1, group 2, and group 3. So group 1, again, we have a variant that is HPV 16 and 18, which is supposed to be carcinogenic. HPV 17 and 13 are probably less carcinogenic in humans, and remainings are also at under trial. Transmission, there are two routes of transmission: horizontal transmission, that is from the skin contact and through the unprotected sexual trends; vertical transmission from the maternal cervix. We are totally focusing on human papilloma viruses, which are the prime suspect of the etiology of oral squamous cell carcinoma because of their morphological association with SCC and their ability to change the oral layers, that is keratinocyte layers, and bring about the transformation into epithelial cells. The buccal mucosa being the site that is most exposed to the chemical carcinogens, and they are more susceptible for HPV by making it easier the virus to gain entry into the basal cells. Coming to structure of HPV and why I'm going into the HPV structures, the entire HPV structures, we have a viral replication. Only the E6 and E7 fraction is oncogenic. So I hope everybody will understand what is oncogenic. They are oncogenic so that they can promote the oncogenesis in the human cells and especially in the keratinocytes. So coming to just giving everybody knows about these layers. So what HPV does here, you can see this red this thing. They basically attack keratinocytes, and then they'll start the synthesis of viral proteins in the keratinocyte layer. There has been a wide variation in HPV positivity rates in the cancers in different sites of head and neck region. Approximately 25 to 75 oropharyngeal carcinomas have been tested for the HPV positives. And rates are higher in the tonsillar and highest being the tongue and the buccal mucosa. In one of the study, 74% of squamous cell carcinoma removed from the lateral aspect of the tongue are found to be positive for oncogenic subtypes of HPV, while other authors are also reported up to 91% of prevalence in the tongue cancers. So coming to, when you see the etiology as per the age and gender, squamous cell carcinoma usually seen in the older age group, whereas squamous cell carcinoma, which has got an etiologic potential from the HPV virus, has got a much younger age group. That is, younger age groups people are more involved. When tumor site is variable by the age, the highest frequency is the tongue, oral cavity in younger age group. So what is this thing to be noticed here is younger age group and the people who practices the multiple sex partners, because it get transferred to the secretions. HPV is more three times pre-cancer. People have pregnant also they have found it is about 5 times more likely than the normal mucosa. In one of the review, 16 studies on leukoplakia reviewed, HPV was prevalent in 14.8 cases, approximately 15 cases, and looking into the age, that is 40 years. Whereas our squamous cell carcinoma, which we usually see in our OPD, they are more than 50 or 60. But here it is 40 years. Verrucous carcinoma has showed about prevalence rate 27%, and demonstrating the virus has a greater predisposition for the buccal mucosa, and commonest being HPV 16 and 17 in 47 cases. Association as a carcinogen. Certain studies have shown HPV is associated with the increased risk of up to 3 times independent of exposure to the alcohol and tobacco. So if the person are not exposed to the alcohol and tobacco also, then also if they are exposed to HPV, there are more chances of getting a oropharyngeal tumors, although with the less tobacco usage and less alcohol consumption, but with a history of orogenital sex. So in an North Indian studies where oropharyngeal cancers have showed highest incidence with HPV positivity, the recent study conducted in the Northeast India where HPV DNA positivity along with the tobacco and the alcohol was shown the highest prevalence rate. Now coming to prevalence in Indian oral cancers, different parts. The tongue and the floor of the mouth has got in a Western countries, buccal mucosa in India, tobacco and betel nut quid in the gingival sulcus area. In it, 33% is also seen in the eastern part of the India, and in South India, 67. Point to be noticed here is 67% in South India have shown the HPV association with squamous cell carcinoma, whereas 15% in the Western India. So the least being Western India and highest being the South India for the prevalence of HPV in this patient. In short about the methods of detection, light microscopy is used, southern blots are also used, and highest frequency, everybody knows for viral infection, we need a PCR studies, polymerase chain reaction. Future directions, understanding the role of HPV in the etiology of oral cancers is essential for the diagnosis, prognosis, especially prognosis and treatment of oral cancer. I'll not go into the details of pathology. It has got, we already discussed, it has got viral genes, which we call it as a oncogenes. E6 and E7 fraction of HPV virus has got an oncogenic potential to form squamous cell carcinomas. Coming to the less frequency, everybody knows Epstein-Barr viruses, Burkitt's lymphoma, Hodgkin's lymphoma, and nasopharyngeal carcinomas are also seen. Epstein-Barr virus. Now we are shortly, I'll brief about viruses which are less frequently, but they are also named here and they are also studied. Epstein-Barr virus, hepatitis C virus is seen in hepatocellular carcinoma. Squamous cell carcinoma is also seen in the HCV patients also. Then oral lichen planus is also seen in HPV, also showed the association between hepatitis virus and oral lichen planus. So there is a take-home message is the molecular pathology molecular pathway, the human papilloma virus triggers the malignant transformation of the tissues that differentiate from the well-known risk factors. So we have to slightly move from the smoking and alcohol and start looking into the viral etiology for head and neck cancer, especially squamous cell carcinoma, when it comes to the oral cavity, posterior part of the tongue. So carcinoma, squamous cell carcinoma involved with the posterior part of the tongue tonsils have got a higher frequency for HPV virus. Thank you for giving me an opportunity. I have just given a brief outline about role of viruses.
It's a great insight on role of viruses in oral cancer. From audience, anybody want to ask any question, they can ask to our senior faculty, Dr. Baswaraj. He's with us, and you can ask question. Anybody who can unmute the question, or you can ask a question by typing in chat box.
Sir, good evening, sir. This is Dr. Abhay Kulkarni.
Yes, Dr.
As
Abhay,
you
yes.
said,
Yeah.
is it got, only malignant transformation, does it got a role, or formation of oral cancer also it has been proved some role? Like,
I am getting your question. You need potentially malignant lesions and carcinoma in situ have a role. Sir, as per the present literature, we have on a pre-malignant lesions like leukoplakia and like pre-malignant conditions like lichen planus, as per the literature study.
Yeah.
But during the transition, that is from the epithelial dysplasia to the complete epithelial dysplasia to the carcinoma studies, the studies are very less. They have proved in the known and the diagnosed cases of SCC, squamous cell carcinomas, and pre-malignant lesions like leukoplakia and lichen planus. But during the transition, that is what you mean to say, carcinoma in situ, the studies are very less.
Okay. Like as a researcher, if I want to work on this aspect itself, like what topic you particularly will suggest that you take these topics and proceed?
Sir, when it comes to HPV, there are two studies. One is you can take the local lesion scrapings and send it for HPV titers. And the second one is you can take the serum and send it for a HPV antibodies. But coming to HPV antibodies, they are very expensive. Most of the studies done in India are on the from the surface scrapings and then HPV positive or a negative. So when it comes to the antibody titers, very few studies have been done. So whatever they have done, they have taken the surface lesion scraping and sent it for a HPV, because these HPV detection is routinely done in a gynecology practice for the cervical cancer.
Yeah. That is been done in the gynecology practice.
Yes. So slowly now they are putting efforts in state of Punjab now for high school going children, females, they are advising those who are above 15, they can go for a smear and look for their predisposition for HPV. Because what happens?
The way HPV vaccine is been given, sir,
yes,
for
sir,
prevention of
yes, it is given freely in the state of Punjab.
Same way.
Yes, sir. But coming to it's because according to the literature, the serum fraction has got more oncogenicity as compared to the lesions.
So serum testing will be much more reliable. That's what you want.
Yes, definitely, sir, definitely.
No. What I wanted to tell, in a pre-malignant condition, oral pre-malignant disorder, suppose if we detect presence of HPV and all those things, are there chances that if we give vaccine or try to control the viral load, the chances that we can prevent it going into the squamous cell carcinoma stage?
Yes, probably may be there. But sir, again, we have to give a vaccine and then we have to do the antibody tests. If antibodies are raised against the HPV, then it is protecting. But since the vaccines are giving only for the gynecological person, uterine cancers. So it is not very less. Very less population has been tried in oral cancers.
Yeah, we can design such vaccines then, sir.
Definitely.
That will be.
We can design, sir, possibly the same vaccine because the virus strain is same only. Same vaccine can be used.
Yeah. Okay. Thank you, sir.
Thank you, Abhay, sir. Thank you for your inquiry. Thank you, sir. Thank you. Anybody want to any queries? I'm thankful for organizing committee.
Yeah,
yes,
Dr.
sir.
Baswaraj, there is one question from Dr. Pooja Wadhwa. She is
Yes,
asking
yes.
that our viruses are responsible for breast cancer and oral cancer. What is the manifestation in mouth actually? So she is asking.
Sir, can you repeat the question? I'll just see in the chat box if any chat box questions are there.
Chat box is a very generic question.
Yes, sir. Our viruses are responsible for the breast cancers. Sir, as such, those viruses, as per the literature, there is no coincidence between the oral cancer and the breast cancer, because oral cancer may be metastasized into breast, but the role of viruses in relation to breast cancers, very few studies are there. I think Pooja will be happy with. Is it okay, Pooja? Viruses, you are telling viruses are responsible for the breast cancers. Very few studies have been done. Viruses are responsible for uterine cancers. It's already proved. Viruses are responsible for oral cancers. Still trials are more, because they have done on a surface proteins, that is surface HPV proteins, not on serum fractions.
Okay. Thanks, Dr. Baswaraj, for bringing this role of virus actually. You were saying that it's about to be proven that the role of viruses in oral cancer, though it's proven already in uterine cancer and all. So thanks and all. You have already taken questions of 2-3 questions. Now we are moving with the paper presentation competition of faculties. I hope that the faculties, there are 10 faculties we have shortlisted and they are in the Zoom room. And the judge is Dr. Baswaraj, who is with us, who is our previous speaker. And he will be judging and asking the question to all our faculties. So the first name which is in our list is Dr. Aditya Dupare, but he is not in the meeting room. I just checked. So the next one is Dr. Rajuta Patil. Dr. Patil is there in the meeting room. So Dr. Baswaraj, can you stop sharing your presentation so that Dr. Rajuta can share her presentation? Dr. Baswaraj, could you stop sharing your slide? You are in. Can you unmute, Dr. Baswaraj?
Sir.
Yeah, your slide is already shared. Can you stop sharing your slide?
Yes, sir. Sure, sir. I'm doing it. 1 second, sir. I'm doing it. I think it is done, sir.
Yes, done. It's done. So, Dr. Rujuta, can you share your slide, give your brief introduction, and start your presentation?
Sure. Yes.
I think you are coming, second or third time in our program in the MedSkill and National Health Academy program, if I remember.
Yes.
Okay. Yes, your slides are visible, Dr. Rujuta.
Is it visible?
Yeah, it's visible.
Thank you. Yeah. So, good evening, everybody. Myself, Dr. Rujita Patil. I'm a periodontist by profession and also an oral cancer screening consultant. So today I am presenting a paper on artificial intelligence in oral cancer diagnosis, clinical management, and prognosis. So as we know that the oral cancer cases are rising at a faster pace in India, and amongst the 3 deadliest cancer, it stands at first in females and first in males and at fourth in females. This is a report by Globocan 2022. With this regard, moving to the role of oral AI in oral cancer. So AI has drawn a specific interest among the scientists worldwide because it mimics human cognitive functions and marks a significant technological advancement. So we have seen that the and also the studies state that the AI helps in overcoming certain difficulties with respect to cancer is the detection, prognosis, prediction, and effective management. And it also helps in lower mortality rates by promoting early detection and therapeutic approaches. So with considering this in mind, we conducted a systematic review to critically evaluate the available evidence concerning the accuracy, sensitivity, and specificity of utilizing AI in oral cancer detection, diagnosis, prognosis, and effective clinical management, and also to assess the AI-based models in oral cancer detection, diagnosis, management, and prognosis. So our systematic review is already registered in Prospero, and we have followed the PRISMA 2020 guidelines in reporting this trial. So the research question with which we began is, are artificial intelligence-based models effective in oral cancer detection, diagnosis, management, and prognosis? So for this, we used a PICO model. A patient, first the P stands for patient, that is the patients where the suspected or diagnosed with oral cancer at any stage or grade. And intervention was the AI-based models designed for oral cancer detection, diagnosis, therapeutics, as well as prognosis. Comparison, we tried to compare it with, we tried to include studies that have done some comparison with the conventional modality if the data persists. But if it was just simply an AI tool that was used, then those were also considered. With respect to outcome, efficacy of AI-based models in oral cancer diagnosis, management, and prognosis, that was the major or the primary outcome. And for that, defining this outcome, we had considered the radiological as well as the pathological aspects, the recurrence identification by nodal metastasis, survival rate, and also possible outcome of surgical procedures performed or non-surgical therapies. We aimed at measuring the accuracy, sensitivity, and specificity of this AI models in their overall performance. And the secondary outcome which we tried to measure here was like the oral cancer associated complications, post-therapeutic complications like oral mucositis and or osteoradionecrosis of the jaw. So the inclusion and exclusion criteria, basically it was different for both the studies and the patient aspect. For studies, we included all types of studies, randomized control trials, cross-sectional studies, case control studies, etc. But those who were published in English language only. And exclusion criteria was like narrative reviews, systematic reviews, case reports, case series, book chapters were excluded, and also animal studies were included. Only studies done on humans were considered. For patient inclusion criteria, ages between 18 to 80 were included, and males and females who were suspected or diagnosed with oral cancer. And the important criteria here was that the primary cancer site should be oral cancer, and it should not be a secondary site or the metastatic site. And the way we began the methodology was the search strategy. We included PubMed and Google Scholar, and we included certain keywords like artificial intelligence, neural networks, deep learning, machine learning, and we came up with the PRISMA flowchart. Here, the study selection has been described in detail. And after undergoing 700 odd studies, and the detailed analysis of all these studies, we included 5 studies in this systematic review in total. And the data extraction was performed by 3 reviewers. Those studies which were included were numbered as 1, excluded were numbered as 2. And the quality assessment was done by Joanna Briggs Institute Critical Appraisal Checklist for Qualitative Research. And the risk of bias assessment was for the included 5 studies was done. So coming to the results, we found that these were the 5 studies that were included. 3 of them had moderate risk and 2 of them had lower risk. So let us go in about each of the study. Study 1 was about the detection of the cervical lymph node metastasis from the oral cancer, and they used a EGSVM based IR imaging system, and they wanted to see whether this is a potent screening and diagnostics tool for detecting the cervical lymph node metastasis from the oral cancer. They did a comparison with the manual qualitative analysis, and this EGSVM is nothing but the entropy gradient support vector machine. It is also type of a machine learning tool. And they saw that the sensitivity, specificity, and accuracy was higher with respect to this EGSVM based IR imaging system compared to that of the manual qualitative analysis. And they had one more aspect here is they compared the infrared imaging with the contrast CT images, and they said that it was not, both were comparable, and EGSVM based IR imaging was non-inferior to CT. And in fact, they showed that the EGSVM, the trend was that it had higher sensitivity compared to CT, which had higher specificity. So in toto, they said the advantages of this being the visibility. The human naked eye has there could be one disadvantage is that it can only visualize larger areas, and the smaller areas could be ignored, and that could be achieved better with the EGSVM based IR imaging. And also inter-observer variability can be reduced, and also the time within 1 minute the images could be analyzed with the EGSVM method, and that's how it can improve the efficacy as well. So due to the satisfactory performance, authors anticipate that it can be a reliable and reproducible tool for classification of these kind of thermal images. So next study was to differentiate between the benign dysplastic malignant oral ridges using autofluorescence spectrometry. They compared here the PCA, the artificial neural network, red-green intensity, and they saw that there was the all these methods which they employed were better only in differentiating healthy from the malignant, but not the benign and the pre-malignant. It was measured using the receiver operator characteristic curve, and this curve shows 0.9 to 0.97, and whenever the point it is ROC AUC curve is more than 0.9, it shows that it is performing well. So they said that all of them were comparable, but yes, only for differentiating between healthy and malignant. The third study, they tried to predict the occurrence of oral mucositis in patients who have undergone head and neck, who are having head and neck squamous cell carcinoma, undergoing radiotherapy alone or in concurrent with the chemotherapy. And here they graded 0 as absence of mucositis, and grade 1 is asymptomatic or mild mucositis. And this was a significant factor because they wanted to see the changes, that is early mucositis which was seen. And they say that the accuracy for the training data set was 100% and 82% for the testing data set. Here they used a deep learning model, that is convoluted neural network model was used. And they stated that out of this entire around 290 around patients were used. And in that 78 patients were the testing data set, and they showed 82% accuracy was seen. So they here, although the false negative rate was 14.9% and false positive rate was 17.9%, their focus was to reduce the false positive and false negative rates, and which is because these are the critical factors which influence the diagnostic system. They say that it is a good diagnostic tool for measuring the early occurrence of oral mucositis. The fourth study here, they tried to compare between the survival of the oral squamous cell carcinoma, and here they compared two AI models, that is ANN and LR, and also ANN was compared with the LR, which is a conventional model, and they wanted to predict 2-year survival rate. And here they said that, of course, ANN was better and it had showed more sensitivity and specificity. But whenever, and in certain cases where 3 variables were used, like tumor size, nodal stage, and race, LR also showed a better performance, but whenever the more predictive variables were used, ANN performed in a better way. So the next study, they wanted to see the risk of developing oral cancer in patients who have had the habits, and also based on their demographic profile. And here also the accuracy, sensitivity, and specificity are follows that are mentioned here. They tried to compare between fuzzy neural network and fuzzy regression prediction and oral cancer clinicians. In one or the other way, so the accuracy was sometimes better in the AI models, and sometimes the specificity was better in the oral cancer predictions. But it is a mixed opinion which they have got. They say that it depends on the number of the input predictors which they are putting in. Where if the input predictors are like more than 3 and 4, then the AI model can perform better, even better than the even sometimes it can help the clinicians in predicting these the possibility of developing oral cancer in a better way, is what this study states. So overall, the performance of the sensitivity, specificity, and accuracy ranged between 45 to 84, 54 to 85, and 59 to 82. But here it was see that the artificial neural network and the deep learning, that is the convoluted neural network, the range was it was nearly above 70%. Only the logistic other neural networks there, it was near towards the lower end. So ANN and CNN has performed by far well in all of these cases. So in conclusion, the AI can be used as a significant, it can be used in aiding the clinicians in early cancer diagnosis, prognosis and treatment efficiency. And within the present limitations, like smaller set of data sets were used, and also the improvement, still these were, some of them were pilot studies. So considering all these limitations, can be said that both the machine learning and deep learning can be used effectively in early detection, diagnosis, management, and prognosis of oral cancer. That is irrespective of the AI model that is used. So thank you. At last, I just want to say that decision making is something that cannot be left to AI. One needs to evaluate all the data and use past experience to take a decision. This is where human intelligence comes to play. Thank you so much.
Dr. Bhagwati, over
Yes,
to you for the question.
Dr. Rujita, it was a nice presentation.
Thank you so much.
And you have taken a very good topic, that is on current modality of assessing the disease to oral cancer.
Yes.
My question is,
Yes.
since we have advanced technology in radiotherapy and chemotherapy,
Yes.
if you take the survival rate for 5 years, then you could have got the better accuracy and specificity, or it will be same. Are you getting my question?
Yes.
Ruchita?
Yes, sir. Yes, sir. Please.
Yeah.
Can you just repeat it once again? So, like the context.
Since we are using a much better chemotherapeutic agents and radiotherapy models.
Yes.
If you take a 5-year survival rate,
yeah.
So does it change your specificity and sensitivity?
Yes, definitely, sir. It will change.
Okay.
It will change. It will change because I think that's what is the case here. It is the type of the data that we are putting into the AI model. Then I think it would be better if we increase the survival rate, and then the specificity and sensitivity will also vary according to that. And also the stage, the grade, the metastasis. There are so many factors that decide the survival rate. So yes, it will definitely vary.
Good. Which AI model you have used here?
Here, so
Is there any specific AI model for oral diseases or oral cancer?
Here they have not mentioned exactly, but these were all, I think, inbuilt within the institution or something. But the model which they have used is convoluted neural network. That is a deep learning model in one of the study, and artificial neural network has been used. And also there is one more support vector machine. I think that was a very nice study wherein they tried to evaluate, I think, this one. This first study, the support machine, where they tried to see the difference between like the low lymph node metastasis. This was one more different. It was not a deep learning model, but still it showed greater sensitivity, specificity, and accuracy, and that is remarkable. And here they say that there is the infrared imaging which they are using. It is non-invasive, and there is no need of any contrast to inject in the patient's body. So I think that is the advantage, is what they state. So these are different models, and the support vector system is basically a machine learning model. Yes.
Okay, good. Yes.
Thank you.
A very good presentation, Dr. Rujita. You have
Thank you so
brought,
much.
latest in diagnosis of, prediction of oral cancer diagnosis, the AI. We are going to the next presenter. Dr. Rujita, from which university you are?
Sir, I'm from Rajiv Gandhi University of Health Sciences. I'm Bangalore. I'm actually a
Bangalore.
university rank holder as well. Yeah. Yes.
Okay, great.
Thank you.
And you are a reader over there, means associate professor or lecturer, what?
I'm actually associated like an adjunct faculty, not in Bangalore.
Okay.
Not in Bangalore, but at my home place, Alamin Dental College. Yeah.
Good.
Yeah.
Okay.
Thank you.
Thanks. So we are moving to the next presentation. There is a name which is I got from my backend team, but I think Dr. Aditya Dupare, he is not available actually. So we are moving to Dr. Shailaja. Dr. Shailaja, are you there?
Yes, sir.
Yeah. Please share your slides, give your brief introduction and start your presentation.
Sir, I am not finding the slide share button over here, sir.
It's on the in the bottom. There is a green
Yes,
color.
got it, got it, got it.
Slide.
Sir, is my slide visible?
Not yet, but we are waiting. Yeah, it's coming, but yeah, no, it's visible. You just make the
Yes,
slide
yes,
show.
sir. I'll change it to slide share.
Yeah.
Now, sir?
Yeah, it's visible and good. Yeah.
Thank you, sir. Myself, Dr. Shailaja Attur. I'm professor and head in the Department of Oral and Maxillofacial Pathology and Oral Microbiology. I am thankful for this great opportunity, sir. The topic of my presentation today is oral cancer immunology, the role of natural killer cells. Preclinical researchers now emphasizes understanding the role of tumor microenvironment in cancer progression. These cells are in focus, as evolving research has revealed their diverse mechanism regulating the tumor suppressive and tumor promoting qualities. Among them, natural killer cells are known to have anti-tumor as well as anti-metastatic activities. Natural killer cells are unique in their cytotoxic function as they do not require prior sensitization. They eliminate cancer cells in primary as well as at distant sites. Every clinically significant tumor has somehow evaded this type of control. Recent work has shown that the natural killer cells can be co-opted to promote tumor progression. Therefore, there is an urgent need to understand the role of natural killer cells and to identify the strategies to recruit and sustain these natural killer cells for cell-mediated anti-tumor response. Morphologically, these cells are characterized as large granular bone marrow-derived lymphocytes, and phenotypically they are CD56 positive, CD3 negative, and they represent 10% of total peripheral blood lymphocytes. They are also seen in peritoneal cavities, spleen, liver, lung, lymph node, thymus, uterus during gestation. These cells have a diverse biological role, and they include recognition and killing of virally infected cells as well as the neoplastic cells. Circulating natural killer cells are mostly in resting phase, but they get activated on encountering the cytokines, which will lead to infiltration into the tissue where we find pathogen or infected or tissue cells as well as the malignant cells. There are basically two subsets of natural killer cells, CD56 DIM cells, which are around 90% of the natural killer cells, and they are known to have cytotoxic activity. 10% of the natural killer cells are CD56 bright cells, which are known to produce cytokines. The functioning of these cells are controlled by a wide range of receptors that are expressed on the cell surface, and they include inhibitory as well as the activating receptors. And these are the list of the receptors. Natural killer cell cytotoxicity is tightly regulated by balance between activating and inhibiting signals. The inhibitory signals of natural killer cell recognize the major histocompatibility complex 1 molecules, which will prevent its activation. And this explains why the normal cells are not attacked by the natural killer cells. The activated cells encounter the cells which lack major histocompatibility complex 1. This is known as missing self hypothesis. Virally infected cells and tumor cells often downregulate MHC1 molecules to escape its recognition from cytotoxic T lymphocytes. But this will lead to their vulnerability towards natural killer cells attack. This induces a potent stimulatory signal, tipping the balance in favor of natural killer cell activation, and this condition is often referred to as induced self-recognition. Once the target cell is recognized by the natural killer cells, the cytotoxic activity is mainly dependent on by the release of membrane-disrupting proteins, for example, porphyrins and granzymes, or by activation of cell-dependent capsid-dependent apoptosis, or by antibody-dependent cell-mediated cytotoxicity, or by the release of exosomes. Now let us see the dynamic changes of natural killer cells within the tumor microenvironment. Various chemokine receptors are present on the surface of the natural killer cells, and chemokines are present in tumor microenvironment. These bind and recruit more natural killer cells. The recruited and activated natural killer cells recognize the tumor cells and will cause their death. However, tumor cells can alter the expression of chemokines and thereby alter the natural killer cell recruitment. After entering into the tumor environment, these cells are lethal in the early stages, but in later stages, the cytotoxic effect diminishes. This might be because of reduced expression of cytotoxic receptors, decreased level of activation markers, depletion of natural killer cell markers, or by the inhibition of these cells by the components of tumor microenvironment. Natural killer cell dysfunction and its phenotypic alteration in the tumor microenvironment are often associated with immune checkpoint inhibitory molecules. The low expression of MHC1 on tumor induced natural killer cell exhaustion. Tumor cells can evade killing by natural killer cells via immune checkpoint molecules. Inhibition of the binding of immune checkpoint associated receptors, ligands, enhances the aggressiveness of the host immune system against the natural killer cells. Hypoxia impairs the natural killer cell function by reducing the ability to release cytokines, decreases the expression of granzymes, or damage the mitochondria of these cells, which will lead to apoptosis of these cells. Tumor cells preferentially use glycolysis rather than oxidative phosphorylation for energy supply, which will result in lactic acid accumulation in the tumor microenvironment, which will reduces the pH. This will lead to immunosuppression, immune escape, as well as disease progression. The acidic pH are known to reduce the cytotoxic activity of natural killer cell plus mitochondrial dysfunction, which will lead to their apoptosis. There are a different type of cells in tumor microenvironment that secrete cytokines, which determine the direction of the natural killer cell differentiation. Some subpopulation of natural killer cells synergize with immune or non-immune cells in the tumor microenvironment to promote anti-tumor immunity, but sometimes the action may reverse and lead to malignant tumor propagation. It is essential to explore this crosstalk between the natural killer cells and the cells of the tumor microenvironment to identify the cell population with anti-tumor immunity, which can be used for clinical application. Natural killer cell increase the expression of cytotoxic receptors to promote T cell recruitment. They can also inhibit the T cell function via activating receptors. TGF-beta present in the tumor microenvironment as well as the Treg cells can reduce the action of granzymes and the porphyrins that are released by the natural killer cells. Overall, natural killer cell promote T cell recruitment but suppress T cell function, and the regulatory cells are known to reduce the anti-tumor immunity of natural killer cells. Chemokines from natural killer cell recruits circulating dendritic cells into the tumor microenvironment. Dendritic cells as well as natural killer cell exhibit a positive feedback mechanism in promoting recruitment and differentiation of each other. But sometimes dendritic cells are known to secrete chemokines which can inhibit the function of natural killer cells. Pro-inflammatory and immunosuppressive factors released by macrophages may influence the maturation and function of natural killer cells. Macrophages secrete cytokines to recruit and activate natural killer cells. Sometimes they inhibit the lethal effects of the natural killer cells. M1 macrophages promote the natural killer cell activity, but M2 macrophages, as well as the tumor-associated macrophages, are known to reduce the activity of natural killer cells. Neutrophils promote and inhibit the activity of these cells. Natural killer cell inhibit the pro-angiogenic effect of neutrophil, while tumor-associated neutrophil promote the pro-angiogenic effect of natural killer cells. Carcinoma-associated fibroblasts generally inhibit the anti-tumor immunity mediated by the natural killer cells. Membrane-bound TGF-beta that are seen on myeloid-derived stem cell inhibit the cytotoxic activity. Natural killer cells promote proliferation and metastasis of endothelial cells. Overall, the subpopulation of the cells in the tumor microenvironment and their interaction with natural killer cell may reshape our current understanding of these cells. To conclude, abundant infiltration of natural killer cell into the tumor will increase the patient's overall survival and improves their prognosis. This is all theoretically said, but tumor cells can alter the expression of chemokines and can change the recruitment of natural killer cell as well as the activity of natural killer cell. The complexity of tumor microenvironment result in a dynamic phenotypic changes in infiltrating natural killer cell with a gradual transition from lethal natural killer cell to depleted or immunosuppressive cells. So it is important to understand this role of these cells and their interaction, and the action can be used for clinical application. These are the references, and thank you.
Yes, Dr. Baswaraj, over to you for questions.
Yeah. Dr. Shailaja, you have given a nice insight into NK cells, that is natural killer cells. Are there any studies, serological studies on NK cells in squamous cell carcinoma?
Sir, more than serological studies, NK cells have been studied on the tissue specimens, sir.
Okay.
There are lot many studies, and we are also actually planning to go in for the study, sir.
Okay.
Yeah,
So what is your conclusion in this thing, biopsy specimen studies in they are increased or they are decreased?
Sir, actually they are increased, but the problem is initially the natural killer cells are acting against the tumor. Okay. But the tumor microenvironment is actually modifying these natural killer cells, and they're making it a tumor promotive cell. So we have to actually do more researches to see that which cell is actually activating the natural killer cell cytotoxicity so that it can be used as an advantage for immunotherapy of the cancer.
Okay. So you mean in the initial stages, in the stage 1, they are less, and in stage 4 they are increased?
Sir, it's not actually like that. It depends from tumor to tumor. Initially, when the natural killer cell enter into the tumor, their basic function is anti-tumor. Okay. But later on, depending on the other cells within the tumor, the cytokines that are released by the other tumor cells as well as the inflammatory cells, it can happen that instead of having cytotoxic activity, these cells are promoting the growth of tumor. It is similar to the T regulatory cells, sir. They are actually helping in, for example, they will help in recruitment of more endothelial cells and giving better circulation to the tumor so that it is helping in metastasis and spread of the tumor.
You mean to say they have a biphasic response?
Yeah, exactly, sir. Exactly. There is an immunoediting which I can otherwise call as.
So can it be used in immunotherapy?
So we have to find a way which is actually activating the cytotoxic activity of natural killer cell, which can be used in immunotherapy. Okay. The research is on for that, sir. The cells activating the cytotoxic activity.
Okay. Thank you, Dr. Shailaja.
Thank you.
It was a nice presentation.
Thank you, Dr. Shailaja, for joining and sparing your precious time and presenting the presentation on NK cells. You are from which university, Dr. Shailaja?
Sir, I am from Sakalchand Patel University, Gujarat, sir.
Gujarat. You are joining from Gujarat.
Yes, sir.
Okay. Okay. Nice presentation.
Thank you very much, sir. Thank you.
Okay. So now moving to our next presenter, Dr. Soumya. Dr. Soumya, are you there? Could you please unmute yourself, open your camera, share
Yes,
your
sir.
slide?
Good evening, sir.
Very good evening. Very good evening. You just share your slide. Yes. Your slides are visible.
Slides are visible, sir?
Yeah.
Is it visible?
You just give your brief introduction and start your presentation.
Yes. Good evening, everyone, to the respected jury members and the organizing committee and the audience. Myself, Dr. Soumya, I'm representing the Faculty of Dental Sciences, Ramaya University of Applied Sciences. So I would like to present my study on predictive computer-based application for the early detection of oral cancer. So these are the headings under which I am discussing my presentation. As we all know, oral squamous cell carcinoma is the most prevalent type of oral cancer and poses a significant global health burden due to its high morbidity and mortality rates. And according to the recent Global Cancer Observatory, there were around 377,000 new cases of oral cancer worldwide, with the highest incidence in Asia, accounting for a substantial proportion of all oral cancer cases. So as we can see in this depiction, it is the third most oral common cancer in India, and it has the ninth highest incidence worldwide. And therefore, early detection is the key for successful treatment and management of these patients. But however, usually patients come at a very advanced stage, and there are chances that the patient's treatment or the prognosis is going to be really poor for these patients. Therefore, the aim of the present study was to design and implement a predictive cloud-based application for classification, clinical correlation, early identification, and risk stratification of oral cancer using computational pathology. The objectives were to perform automatic binary classification of oral squamous cell carcinoma histopath images using deep learning, to develop a deep learning-based pipeline which performs extraction of risk parameters, to devise risk stratification based on the extraction and analysis of these parameters, and to build a web application for the clinicians to access the pipeline and deploy a web application on the cloud platform. So initially, the methodology was to capture the images, and then they were annotated using RoboFlow with an expert supervision. And then data analysis was done. So as you can see, first the image was annotated and then data analysis was done. Here we have considered only three parameters, that is keratin pearls, multiple nucleoli, and vascular invasion. Then augmentation techniques were applied through using RoboFlow, which significantly increased the data set volume as well as enhanced the model generalization. And then we did pre-processing of the data set under the supervision of the pathologist. And this was mainly to ensure that data set diversity was looked into to encompass variations in tissue morphology and staining characteristics. So as we can see, the first image is that of a normal oral mucosa. The second image is that of a oral squamous cell carcinoma, which can be diagnosed under the histopathology. However, we are trying to look at the risk parameters. The first one is the vascular invasion. The second one is the keratin pearls, and then the multiple nucleoli. So as I said, first annotation of these images were done using RoboFlow software. So the first image shows how the keratin pearls have been extracted using the RoboFlow, and it has been annotated. The image below this shows how the vascular invasion component has been annotated, and the third image shows how the multiple nucleoli cells have been identified or annotated using the RoboFlow software. Then we used the user interface module, mainly the deep learning or the convolutional neural network. And this was mainly used, in this we used a type which is called as the efficient net. This was mainly used for cancer classification. And then the feature extraction was done using YOLO version 8. And then we use we try to store the images, the histopathological images in the Amazon Web Services. And then we store the clinical images of the patients in the Atlas Mongo database. So this was mainly the cloud platform which we used. So initially, we upload the patient details and the whole slide images into the Mongo database. And the images were also saved in the Amazon Web Services. And this helped in classification of the oral squamous cell carcinoma. And then we try to stratify the risk of the squamous cell carcinoma using these parameters, that is keratin pearls, multiple nucleoli, and vascular invasion. And keratin pearls were mainly stratified based on the area of the keratin pearls, whereas the multiple nucleoli were assessed based on the number of detection and vascular invasion, either by the presence or absence of vascular invasion. And then the pathology report was generated. So we basically used efficient data net, where we took 1,000 cancerous and 1,000 normal oral squamous cell carcinoma images. 80% of the images were used for training and 20% was used for testing. Then these were the augmentation and training parameters that were employed. So why we chose efficient net as one of the tools was because of its optimal accuracy, because it was designed to scale uniformly across the depth, width, and resolution of the image. And then it could also be effectively fine-tuned using pre-trained image net weights. Therefore, the accuracy was highly improved. And then we did feature detection for all these three features. So mainly the keratin pearls and multiple nucleoli, we used YOLO neural architecture search version, and we compared it with the versions 5 and version 8. And for vascular invasion, we used efficient net software mainly to classify whether there was presence or absence of vascular invasion. So why YOLO neural architecture search was mainly used? Because it could automatically design the optimal neural architecture for the given task, and there was no need for any manual tuning. And therefore, there was a more effective model. And the performance and speed also was superior as compared to the other methods. And it was also very easy to adapt to complex databases, and it outperformed the earlier versions like version 5 and version 8. Therefore, this was used. And then we try to classify the risk. So here we have used the Anarod's multifactorial grading system for classification of the keratin pearls, multiple nucleoli, and vascular invasion. So we basically stored the patient's clinical information and the results in the Mongo database. We stored the images in the Amazon Web Services, and we used softwares like Python and Flask for web development. So this is a schematic showing the web application deployment. And these were the results. So when we try to compare the different convolutional neural network tools, we found that efficient net was found to be superior with a 99% accuracy in classifying oral squamous cell carcinoma. Then when we try to look at the extraction or identification of the keratin pearls, which was one of the risk factors, we found that YOLO NAS was superior as compared to version 8 and version 5, and it showed an accuracy of around 92.5%. And for vascular invasion, we found that efficient net was superior with a 99% accuracy in extracting the features of vascular invasion. And then we try to develop a web page where we enter the login details for authentication, and then we enter all the patient's details for stratification of the risk. Then we have to upload the patient's images into the web page. So here it will classify based on the area of keratin pearls, based on the number of multiple nucleoli, and whether there's presence or absence of vascular invasion. You will get the results in the web page saying that whether it is of high risk or low risk. So to conclude, we created a cloud-based AI tool to predict and stratify the risk of oral cancer by utilizing deep learning algorithms and cloud computing resources. So there was an improved accuracy in distinguishing between cancerous and non-cancerous lesions, and also identifying the aggressive oral cancer lesions. EfficientNet model surpassed other models in classifying oral squamous cell carcinoma histopath images and achieved high levels of accuracy, precision, and recall. And YOLO-NAS model was very essential, and it was of improved accuracy for identifying the multiple nucleoli and keratin pearls. And they incorporated Amazon Web Services for a user-friendly interface for uploading the patient slide, images, and clinical data. But what were the challenges that we faced? That it was a laborious endeavor requiring meticulous manual annotation of the entire features. And also, we have to take into consideration the patient's data, the sanctity of the patient's data because of the security and privacy issues. So these are my references. I would like to thank the Department of Computer Science and Information Science for collaborating with us in this particular project of MS Ramaiah Institute of Technology. Thank you.
Thanks, Dr. Soumya, for giving your presentation. Over to you, Dr. Basavaraj, for a question. Dr. Basavaraj, are you there? There might be a technical issue, so that Dr. Basavaraj Bhagwati is not in the room actually. He might be joining for a while.
Okay, sir.
So, Dr. Soumya, stay with us. Maybe Dr. Basavaraj will join again and he will ask a question.
Okay, sir. Sure.
You are from MS Ramaiah or?
Yes, MS Ramaiah Dental College.
Good. Is it based in Bangalore?
Yes, sir.
Okay. So we are moving to the next presenter, Dr. Soumya. Dr.
Okay,
Basavaraj just, I think, join in. Just wait for a while. I think. Dr. Soumya, we are going to the next presenter, and when Dr. Basavaraj join again, he will, take some questions and all. Yeah.
Okay, sir. Sure.
Our next presenter is Dr. Dominic Augustine. Dr. Augustine, you are visible. Could you please?
Hello, good evening, sir.
Very good evening. Very good evening.
So can I share my screen?
Yeah, you can share your screen. Yes. Your screen is visible.
Can I start, sir?
Yeah, you can start.
Yes. Good evening, everyone. I'm Dr. Dominic Augustine from the Department of Oral Pathology and Microbiology, MS Ramaiah University of Applied Sciences, Bangalore. So I thank IOCCON 2025 and MedSkill for giving me this opportunity to present in front of all of you today. So the topic of my presentation is the development of a novel nanoemulsion based histopathology slide for the early and accurate diagnosis of oral cancer. I'll be presenting under these headings. So normally to diagnose any lesion under the microscope, the routinely used stain is called hematoxylin and eosin stain. But however, due to the subjectivity, lot of problems arise, especially in cases which are of borderline. Sometimes we are not sure if it is normal tissue, if it is dysplastic tissue, or if it is a frank cancer. This can happen on occasions where the basement membrane is not visible properly, or it depends on how the biopsy is taken. So sometimes dysplastic tissue can get diagnosed as normal, and on many occasions, oral cancer can get wrongly diagnosed or misdiagnosed, or it can get underdiagnosed as dysplasia. So this is the problem with the routine staining, which is called HNE or hematoxylin and eosin staining. To overcome this ambiguity and dilemma, we are trying to solve the problem by incorporating nanoparticles into the glass slide. So can nanoparticles help us accurately identify oral cancer? What is our oral dysplastic lesion and what is normal tissue? So let us see. So normally this is how a pathology slide is prepared before we give the final diagnosis to the patient. Once we receive the biopsy, it undergoes tissue processing. It is embedded into a wax block, and then the procedure shifts to the lab where a 4-micron thick tissue section is taken and it is stained with hematoxylin and eosin stain as it is seen here. So staining is a tedious process. There is a lot of subjectivity and uncertainty, like how I said, with hematoxylin and eosin, which is basically purple and pink. Everything is going to appear purple and pink. In frank cases, no problem. But whenever there is an overlap of features, there is a dilemma. So then it becomes very difficult because we have to give the accurate diagnosis. And only based on the correct diagnosis, the patient will be treated. So we have developed what is called as a nanoslide, and we have fabricated this in our university. So this is the basic structure of the nanoslide. We will have a conventional quartz slide in the middle. We will coat it above and below with this schematic blue color depiction, which is going to be a nano emulsion that we are going to formulate. On top of this, we are going to place the patient's specimen or the tissue. So this is going to bring about objectivity based on the tissue intensity, not whether it is purple or pink color, which can be subjective. And this is also going to eliminate the staining step. No need of hematoxylin and eosin staining, which is a lab procedure. So this is going to make it economical, and this glass slide can be reused n number of times. We don't have to again purchase new glass slides for our lab. So these are the advantages. So let me show you how we prepared this. So the aim of the study is to develop a nanoemulsion based histopathology slide for early and accurate diagnosis of oral cancer. So first we want to formulate the nanoemulsion base, which we are going to coat around the slide. Then we are going to coat this around the slide using a special spray technique. So for this, the nanoemulsion has to be a good adhesive, otherwise it will fall off the slide. And finally, we want to evaluate the efficiency of the conventional microscopic diagnosis with the nanoslide for 3 study groups, that is normal tissue, dysplastic tissue, and oral tissue, and oral cancer, sorry. So we obtained ethical clearance from our university, and we did this in collaboration with our physics and chemistry department of MS Ramaya University of Applied Sciences. So the nanoparticle we used was called eurobium, and this is the formula of the nanoparticle. We used it at a composition of 9 mole %, and this was the nanophosphor. To make this a good adhesive and to stick to the glass slide, we used a Nafion binder, and we subjected this to a process of sonic emulsification. So a sonotrode was used, which is presented here. So the sonotrode brings about acoustic pressure and generates ultrasonic waves with cavitation. And this is how the whole emulsification happens. There is breakup of large droplets into small uniform droplets, and this becomes a very nice thin mix, a fine mix. That is how the emulsion is formed. The emulsion was then mixed with PVC, that is polyvinyl chloride, and gold media in a 3:1 ratio, and using a titanium horn probe, which is shown here. This was a very laborious process, and using this probe, it was sprayed uniformly on both sides of the glass slide. As we can see here, this is the blank glass slide, which is used for hematoxylin and eosin stain viewing under the microscope. This is a nano-coated slide which has our nano-emulsion coated. And this we have to activate these nanoparticles, we have to see it only under the ultraviolet microscope or ultraviolet light. So coming to the basic structure once again, this is the nanoslide and 2 coats of nano-emulsion, and we are going to place the patient's tissue on this, and we are going to view it under the ultraviolet microscope. So we can see here under UV light how these nanoparticles change their luminescence and emit a pinkish or a reddish luminescence. So this is the light we want to pass through the normal tissue, through dysplastic tissue, and to oral cancer to see if there are any changes in the tissue. We are going to differentiate the type of disease based on the color intensity. So let's see what happened. So we did a sample size calculation. using the GPAR software, and we determined the size has to be 195. We separated them into 3 groups, that is a normal tissue section 65 potentially malignant disorders or dysplastic tissue, and 65 frank oral cancer cases. So what was the difference we saw? So before viewing under the ultraviolet microscope, we viewed it under the conventional compound microscope. So under the nanoslide, we can see how dark normal epithelium looks. It is dark and it gives a dull illumination intensity. When we see dysplastic tissue, we see that dull illumination intensity reduces. And when we view oral squamous cell carcinoma or oral cancer, we can see that dull or dark intensity has disappeared and it appears much brighter. Now let us see how this very importantly appears under the ultraviolet microscope. So before we go into the ultraviolet microscope, these are the control tissues. So this is how the nanoparticle appears under the ultraviolet microscope. It gives a reddish emission or a luminescence. These are normal dysplastic and cancer control tissues without the nanoslide. So once we place the nanoslide, these are the differences we got at 350 nanometers under the ultraviolet microscope. So we can see normal tissue, which is dull, and dysplastic tissue, we can see very clearly there is an increase in the luminescence. Whereas for oral cancer, the third image here on the right, we can see it is very bright. The oral cancer cells are staining very bright and are exhibiting a luminescence. Especially keratin material is exhibiting a lot of luminescence. We change the wavelength to 450 nanometers, and we can see the background, the red color nanoparticles emitting luminescence, and look how the normal tissue appears completely homogeneous in one plane without any luminescence. Luminescence is increasing now for pre-cancer, that is dysplastic tissue. It is very homogeneous and uniform, and so startling difference for oral cancer. Each cell, we can appreciate its morphological outline, especially the cells exhibiting individual cell keratinization or dyskeratosis. When we change the wavelength under the ultraviolet microscope to 500 nanometers, we saw a very dramatic difference between normal tissue. We can see the epithelium, which is outlined here, is completely dark. Please ignore this lower portion, that is the connective tissue. We are not looking at the connective tissue. When we compare the normal epithelium with dysplastic epithelium, you can see again the change in the color intensity. And when it comes to oral cancer, no doubt, very bright luminescence caused by the nanoparticles which have been coated over the slide. So this difference we cannot get under conventional glass microscope, glass slide, which we view under the microscope. So indeed, the nanoparticles are making a dramatic difference in viewing the 3 study groups, and there is a drastic difference between the study groups with a statistically significant p-value. So what are these nanophosphoparticles? They are engineered at a nanoscale with the dimensions in the order of nanometers, and they exhibit luminescence. So overall, they represent a promising area of research and development with potential for advancements in various technologies. Here we have applied this principle for differentiating normal tissue, dysplasia, and cancer. So what is the mechanism or principle here that we have exploited? So normal cells usually have a nucleus cytoplasmic ratio of 1:4, and normal chromatin is going to absorb all of this UV light, the chemiluminescence light. Because of that, very less light or dull luminescence reaches the observer at the other end. Whereas oral cancer cells have spread out a very thin chromatin. Because of this, there is a change or intense luminescence we can observe. So when a neoplastic cell is exposed to UV light, the chromatin absorbs photons and it gets excited. So this produces a distinct contrast. So neoplastic cells, as I said, has an altered NC ratio, and because of this, higher intensity of light falls on the observer's eye, and we are able to differentiate the 3 lesions, which is very crucial for accurate diagnosis, because many times we have seen borderline micro-invasive oral cancer or early invasive cancer. If the basement membrane is not clearly visible, we would have received the biopsy, but if the basement membrane is not visible and the cells are on the borderline, very difficult to differentiate these. So coming to the original contributions and the conclusion, so we have developed a mechanism where there is reduction in subjectivity. It results in accurate microscopic diagnosis, which is the gold standard to diagnose oral cancer. and it helps in resolving the diagnostic dilemma in borderline cases. And this is a cost-effective production model compared to what is existing. A one-time development would be enough, and we can use multiple tissue sections. We don't have to purchase new glass slides every time. These are my references. Thank you for providing me an opportunity, IOCCON 2025 and the organizers MedSkill. Thank you.
Thanks, Dr. Augustine, for sharing your innovation in the luminescence and all, and how it's a contrast in some new technology. Yes.
Thank you, sir.
Dr. Basavaraj, over to you for a question from Dr. Dominic.
Yeah, Augustine, it's a nice presentation. You have given a new technology for our histopathological study on oral cancer.
Yes.
Thing is, when you come to the sensitivity and specificity,
yes,
is it better than IHC, that is immunohistochemistry, or IHC is better than?
IHC would be definitely superior, sir. But one of the advantages, what I've stated is, this is going to be cost effective. So every time a patient need not spend 800 or 900 rupees for a immunohistochemical procedure.
Okay.
So immunohistochemistry itself can be avoided here when we can identify at the microscopic level whether this tissue biopsy is dysplastic OPMD or frank oral cancer or normal. So that is one of the advantages where higher technique can be avoided, which makes it more cost effective.
You mean the cost of nano is much less than as compared to the IHC?
Yes, sir. Yes, sir. Given the fact we have to purchase a new IHC kit, a kit nowadays costs between 35 to 40,000, and we need a IHC lab and then staining for the technician. If we compare all this, and if we just have this one nano slide which we have developed, so on this multiple tissue sections can be viewed, sir.
Okay, one more thing is, I'm not that good in histopath. When you go to the histopath, you differentiate well differentiated, moderately well differentiated, poorly differentiated.
Yes, sir.
This can be appreciated in nanotechnology?
Yes, sir, we can differentiate that because like I showed, how we differentiate and how we say under the microscope as well, moderate and poor is based on the amount of keratinization. When there's a lot of keratinization, you say well differentiated because it's resembling the epithelial tissue which produces keratin. Moderately, we have very less amount of keratin, and in poorly differentiated, there is no keratin. So like I showed in the third picture with the red wavelength, the keratin very dramatically stands out here in this nano slide. So we can quantify the amount of keratin that is present in the section, and we can say whether it is well differentiated, moderate, or poorly differentiated, sir.
Okay. Nice, Dr. Augustine. Thank you.
Thank you, sir. Thank you so much, sir.
Thanks, Dr. Augustine.
Thank you, sir.
I think your colleague was the last presenter, immediate before you. She is also from Ramaya Institute.
Yes, sir.
You are also from the same end.
Yes.
Dr. Basavaraj, Dr. Soumya is also there. You are, due to some connectivity, you are not there in the meeting room.
Yeah. There is some connectivity issue in the campus.
Okay.
So,
good evening,
if
sir.
somebody else will take up, then I can leave the room. If somebody else, so that accessibility will be there. Okay. I don't mind connecting, but there is a connectivity.
Yeah.
Connectivity issues there. Even for my this thing also there was some.
These are, all are in means we are recording all these presentations, so you can able to see the presentation later on. We have two presenters left actually to complete their presentation. So Dr. Soumya, it would be reviewed by Dr. Basavaraj through recordings and all. Dr. Megha, are you there? Dr. Megha? Then Dr. The last but not the least, Dr. Hajira Khatun, she is the the presenter. Dr. Hajira, are you there? She was there. Yeah. Dr. Hajira, could you unmute yourself and share your slide? Dr. Hajra, are you there? She is in the meeting room, but I don't know what happened actually. There is some technical, glitch. So I think our paper presentation competition is over now. We have 10 presenters and two of them are not available. And Dr. Hajira is there, but she is not responding actually. So now we are concluding for the day. Dr. Basavaraj, thanks for joining us and judging these paper presenters from faculty side. And we have the four speakers today who joined us from different part of India and world. Actually, we have Dr. China. She joined from PGI. Then Dr. Tilak Ratne, there's a dietitian who joined, Dr. Gitanjali Mengi from Mumbai, then Dr. Kulkarni, and then Dr. Baswaraj. So we have five speakers today, and then 10 paper-based presentation. We have tomorrow and day after is a marathon meeting and presentations. We are having some 30 speakers left who would be joining across the world, and they would be sharing their upcoming latest developments and latest trends in diagnosis and management of oral cancer. Rather, some are joining other head and neck oncologists and all. So we are talking about both diagnosis management of head and neck cancer. So we would be joining tomorrow at 9:30, both tomorrow and day after 9:30 in the morning. So we are signing off today for the day, and we'll join again tomorrow at 9:30. Anybody from our attendees want to ask any question, they can unmute and ask question. Anything related to any feedback, any suggestions they want to share to organizing team, I would be forwarding your suggestions.
Good evening, sir. This is Dr. Hajira.
Yes.
If you please allow, can I do my presentation now,
Yeah,
sir?
you can. I'm waiting for you. Yes, sir.
Yeah, thank you so much, sir. Can you see my screen, sir?
Not visible yet, but I'm waiting. It might be visible in a couple of seconds.
Now?
No, I'm not visible yet. I'm just waiting. As soon as I see, I'll let you know.
Okay, sir.
It is not visible yet, Dr. Hajira.
Yes, sir. I think now it will be visible.
I'm just waiting.
Is this loading, sir?
There is some noise coming from background, Dr. Hajira. Could you do something?
1 second, sir. Yes.
We can get a quiet.
Is it better now, sir?
No, it's better. But
Yes,
I
sir.
have yet to see your slides.
Can you see my screen now? I've just played it.
Just we're waiting. It's not visible yet. If it is not shared through your device, can you send my team actually the same presentation so that they can run and you can talk. You can just guide them to move the slides if possible, because your slides are still not visible. Dr. Hajra is exited actually. She is not in room. She is trying, I think. Yeah, she would be trying to rejoin actually. We are just giving them some 2-3 minutes, and if she not join, then we'll conclude for the day. Dr. Hajra is in waiting room. She would be joining. Yes, she is in now. Let's see whether she would able to share her slides. Dr. Hajra, could you unmute yourself?
Yes, sir. Thank you so much for giving me time. So I lost
Not
connection
to
with the
worry.
network.
It happens. Not to worry. Yeah.
Yeah, thank you so much, sir. I'm just trying to share my screen. Somehow it's not happening.
Are you joining from PC, laptop, or mobile? Yeah, it's coming actually. Yes. Okay. Yes. Dr. Hajra, your slide is perfectly visible. Yeah, it's moving as well. Yes.
Yes, sir. Very good evening, everyone, respected jury members and all the participants. I'm myself, Dr. Hajira Khatun. I'm Assistant Professor from Department of Oral and Maxillofacial Pathology and Oral Microbiology. I'm from MS Rama University of Applied Sciences, Bangalore. The topic of my presentation today is impact of CAD-M1 and CRTAM in smokeless tobacco-driven metastatic progression of oral squamous cell carcinoma. So first, let us see what is oral squamous cell carcinoma. It remains the sixth most common cause of morbidity and mortality among all the known malignancies, with 80% deaths occurring in the developing countries. The most commonly affected site in the Indian subcontinent is the gingivo-buccal sulcus, and that is why we have chosen this group of tumors in the topic today. Because in India, most commonly they have this betel leaf and areca nut along with slaked lime chewing habit, which they pouch it in the sulcus. Exactly why we have chosen this set of individuals today. Now, looking at what is exactly is oral cancer, it is nothing but uncontrolled proliferation of oral epithelial cells, which go on to divide continuously and eventually enter the connective tissue. And from the connective tissue, they enter the main circulation into the lymph nodes or into the distant metastasis. Now, our aim as treating physicians or diagnosticians is first of all, it is to prevent and all of that. But when the cancer has already set in, our aim is to prevent the progression of spread. That is to prevent metastasis, basically. So we chose two such markers, which we thought might help in reducing this progression into the systemic circulation, into lymph nodes, and into the distant metastasis. So exactly why we chose CAD-M1, which is nothing but an immunoglobulin molecule that is involved in cell-to-cell adhesion. So basically, what we have a basic idea of epithelium is that the cells are tightly attached to each other using some molecules. One of those molecules is CAD-M1. And in few cases have noted that there is mutation in CAD-M1 in oral squamous cell carcinoma cases. That means the cells will lose attachment to each other over a period of time. So we chose this molecule, and along with that, we chose one more molecule, that is CRTAM, which is nothing but MHC class 1 restricted T cell associated molecule, which is also expressed on the cell of natural killer T cells, CD8 plus T cells, and a small subset of CD4 plus T cells. So basically, it have the CAD-M1 acts as a ligand for CRTAM. So there is a cell-to-cell interaction between these natural killer T cells, or basically the inflammatory cells that we know, and the cells that are present on the epithelium. Now, this action between the ligand and the receptor is where the mutations have been noted, but no such study has been done where they have evaluated both CADM1 and CRTAM expression to see in oral squamous cell carcinoma cases. So this is the first of its kind study which we have taken up to check the association. So this brings us to the aims and objectives of our study. Aim is to evaluate the role of CAD-M1 and CRTAM in metastatic and non-metastatic OSCC arising from the gingivobuccal sulcus in smokeless tobacco chewers. And the objectives is to assess the immunoexpression of CAD-M1 and CRTAM in these subset of people, and to quantify their expression and also correlate the expression with the clinical and histopathological findings. So basically what we did, we selected 10 diagnosed cases of metastatic OSCC samples and 10 non-metastatic samples. So we collected formalin fixed paraffin embedded blocks, and we subjected them to the procedure of immunohistochemistry, wherein all the 20 samples were cut into thin slices of 4 micrometer, and then the antigen retrieval was done using the pressure cooker method, following which it was incubated in primary antibodies, and then secondary antibody of CRTAM, CAD-M1 and CRTAM were used to see the staining reaction. And this is how we obtained the results. It was quite expected, like in line with the theoretical analysis that we have all heard of. That is, in the metastatic OSCC samples, the CAD-M1 expression was significantly low. It shows that the cellular adhesion has been lost, and that is why the cells have migrated into the body or into the lymph nodes. Next, we saw the CAD-M1 expression in the non-metastatic OSCC samples, wherein we saw that the expression was quite good and quite high in the tumor cells, indicating that they have not yet split and divided into the circulation, which is a good progression. So here CAD-M1, we have quantified it like this. That is, we saw the membrane expression of tumor cells and gave the following scoring of 0 to 3, wherein 0 was 0 to 10% expression, and so on, where the maximum grading 3 was 61 to 100% expression. And when we did a statistical analysis using chi-square test, we got a very significant answer, which shows that CAD-M1 expression was significantly lower in metastatic OSCC compared to non-metastatic OSCC samples. Coming to CRTAM, which is quite opposite to it, because it shows that the progression has occurred. It is a marker of progression. That is why in metastatic OSCC samples, we saw a very high expression, whereas in non-metastatic OSCC samples, we saw a very low expression. And this is how we quantified it, since it is seen on the lymphocytes. So we saw the staining pattern in the lymphocytic nuclei, wherein 0 showed absence of staining, and 1 showed weak positive staining, and 2 was strong positive staining. We did the same chi-square test for this, and the result was obviously statistically significant. So this implied that CRTAM expression was higher in metastatic cases compared to non-metastatic cases. Now we come to the discussion of the study. It shows that the contrasting roles of CAD-M1 and CRTAM are highly having a high potential to show metastatic progression of oral squamous cell carcinoma, which is induced by smokeless tobacco. CAD-M1 is a tumor suppressor which shows significantly reduced expression in metastatic OSCC, which aligns with its role in maintaining the epithelial integrity, whereas the CRTAM, which is linked to the immune modulation, it exhibits elevated expression in metastatic cases, suggesting its involvement in tumor progression. So these findings will show that there is an intricate interplay between CAD-M1 and CRTAM, which can be targeted for developing immune modulation therapies. So basically, targeting this group is very helpful in stopping the progression of metastasis in the OSCC cases, thereby reducing the risk and the burden of morbidity and mortality. And this is the study that I have presented. Thank you so much, everybody. These are my references. Thank you.
Thanks, Dr. Hajira, for though you are late, but very insightful presentation.
Thank you so much, sir. And I'm
Latest-
sorry for this.
Yeah. Now, most of our presenters in a faculty category, they are presented a latest technology actually. So all the
Yes, sir.
presentations are, very, and they have presented nicely as well. So our panel have selected a good presentation. We have received around 30 presentations at 30 abstracts from faculty, and they have shortlisted it, and we have 10 shortlisted presentations. So over to you, Dr. Basavaraj, for questions to Dr. Hajira. Yeah.
Yes, Dr. Hajira, it's a very nice study, and
Thank you, sir.
it's with the latest technology, and IHC is supposed to be a good study, and specificity is more in IHC. Everybody believes that, and it is there. Okay,
Yes,
what is
sir.
this thing is, you have taken metastatic and non-metastatic.
Yes,
So
sir.
you have taken a local metastasis, that is only to the lymph nodes, or systemic metastasis also in your cases?
No, sir, we have only taken lymph node metastasis because that will have a general outgrowth so that there's no bias. So we just took lymph node metastasis, sir.
Okay, but the same study can be done in distant metastasis also?
Yes, sir, definitely we can do it.
So there, what you will collect as a researchers, you will collect the blood or the tissue of origin?
I think collecting the blood will be better since we can see the circulating tumor cells and can see the markers which are better expressed there in the circulating tumor cells.
Okay. Thank you.
Thank you so much, sir.
Thanks, Dr. Hajra, and thanks, Dr. Basavaraj. We have already given the closing note actually when Dr.
Thank you, sir.
Hajra was struggling to join the presentation. So I think we have spoken most of the thing. Just giving a highlight for tomorrow's presentation. We would be having
मैं यूं
top.
कह रही हूँ फिर मैं कल जाती हूँ हाँ नहीं वो परसों का रहने दो
Or someone, could you please unmute yourself, Dr. Preeti? Your voice is coming, yes.
Thank you, Nurul sir. Thank you for giving me an opportunity to judge your papers. They are all fantastic. I was happy to join. Thank you very much. Thank you.
Thanks, Dr. Basavaraj. And we'll, love to see you again in our future programs.
Sure, sir.
Yeah,
Sure.
yeah.
Thank you.
Yes. Okay. So I'm just giving you a brief, highlight about tomorrow's program. There would be people will be talking about critical statistics mistakes in head and neck cancer. Then impact of digital technology would be taken by one of the speaker. Then we'll learn about total gastrectomy by pull through approach. An oral and maxillofacial surgeon who would be joining. Then we will be going through the dental records, how to record, keep the record of the patient. Then we have AI. AI is trend actually. So Dr. Pulin Saluja will be talking on then role of PET in oral cancer, then microvascular reconstruction, and there's multiple speakers who are joining from different part of the world, and they would be sharing their insights and all. And then day after tomorrow, we will be joining again tomorrow at 9:30 in the morning, and we would be going till 8 o'clock. The last presentation was for tomorrow is a speaker from United States of America, Dr. Sonal Esha, and she would be talking on utilization of Wellscope and advanced technology in detection of oral precancerous lesion. So with these note, we are closing for the day, and we are joining again at tomorrow 9:30 morning at sharp. Thanks to everybody, and thanks. Good night to all. Thank you.